today's WIN AP chapter of pregnancy, session 2 on pregnancy kidney diseases. And I would like to start this session with a prayer song from Shanmuka, Saivani Madam's son. Let us start the session. Shanmuka, over to you.
Jaya Ganesha, Jaya Ganesha, Kalanka Nirvikalpa, Nitya Satya, Dayaka, Ekadanda, Vakratunda, Ganapate Lambodhara, Jaya Ganesha, Jaya Ganesha. Jaya Jaya Nayaka.
Continue, Sindhu.
Okay, thank you, Shanmuka. And let us start today's session. First, let us start with the opening remarks by Dr. Hitashi ma'am. She did her MBBS MD from SWIMS Medical College, Tirupati. DM and DNB from Osmania Medical College, Hyderabad. She is currently working as a nephrologist at Manasa Kidney Foundation, Tirupati since 2022. Over to Hitashi ma'am for the opening remarks.
Thank you, Dr. Sindhu. Good morning, everyone. I congratulate Dr. Jikki and Dr. Saivani for organizing webinars continuously and enlightening us. And I also thank for this opportunity. So, to conceive and give birth to a child, I feel it is an exclusive right and the most cherished dream of any woman, be it a normal person or a person with renal disease. We all know that maternal renal disease affects both maternal and fetal outcomes. We, the nephrologists, need not discourage our patient to go for conception. But before that, we have to have a meticulous planning, careful risk evaluation, and very close follow-up for the maternal and fetal well-being for better outcomes. So optimal management of these patients needs a coordinated effort from a team of nephrologists, obstetricians, and neonatologists. Some of the drugs we use for renal disease may affect the fetal well-being. We have to have, while treating, we have to think about this and plan the management. And detailed counseling of the patient regarding the outcomes is very crucial in these modern ages of high medical legal risks. We have to plan that and do it well. So today we have 5 young and enthusiastic nephrologists to discuss about urinary tract infections, nephrotic syndrome, autoimmune disease, and CKD post-transplant in the context of pregnancy. We are all looking forward. All the best to you all.
Thank you so much, ma'am. And let us start today's first topic quickly. Pregnancy in post-renal transplant by Dr. Bhavya ma'am. And the moderator of the session, Dr. Urmila ma'am. Urmila ma'am is presently working as a consultant nephrology at Amrita Hospital, Hyderabad. And she's the president of WIN India. Thank you, Urmila ma'am, for your gracious presence. I would like to start this first session with an introduction of the speaker, Bhavya Dasra ma'am. Over to Urmila ma'am for the introduction of the speaker.
I think before we start, let Bhavya start the presentation, ma'am. Okay. Then we will discuss. Okay.
Okay, ma'am. Coming to the speaker's CV, Bhavya ma'am, are you ready, ma'am?
Yeah, I'm ready. I'm ready, Sindhu.
Okay, ma'am. Bhavya ma'am is...
I'll just share my screen.
Okay, ma'am. Bhavya ma'am finished
her... You can introduce Bhavya only. Yeah.
Okay, sure, ma'am. Yeah. Bhavya ma'am finished her MBBS from Gandhi Medical College, and MD from Osmania Medical College, DM Nephrology from Gandhi Medical College. She is presently working as in Mamata Medical College as a consultant nephrologist. She also worked as a senior resident in Department of Gandhi Medical College, Hyderabad, and Omni Hospital, Hyderabad, ESI Super Specialty Hospital, Hyderabad. Over to Bhavya ma'am for your presentation.
Thank you, Sindhu, for the.
All of you should also mention Bhavya has been a very brilliant academic career, has received a lot of university gold medals.
Yes, ma'am.
Thank you, ma'am. Thank you, ma'am. So the topic for today is, my topic is pregnancy post-renal transplantation. So as we know, motherhood is a very longing desire for all the females, and even though CKDs are no exception. So pregnancy is an
Bhavya,
desire for many. Ma'am?
Ma'am, can you put a
slideshow mode in the end? In the lower
Sure, ma'am. Sure. Yeah. Now it is clear, ma'am.
Yes, ma'am.
This is better now.
So, so my topic is pregnancy post-renal transplantation, and pregnancy is a desire for many women, and every woman longs to be a woman, be a mother, and CKD is a no exception, and transplant increases the chance of becoming pregnant. So coming to the history, the first pregnancy post-renal transplant was reported in 1958, and the woman is Edith Helm. She is the first female who has received a graft from her twin sister in 1956, and she became a mother, and she gave to a term gestational baby with 3.5 kg weight. And she went on to have a full normal life, and she died at the age of 55 years. And this is a first positive report saying that pregnancy can happen after a successful renal transplant, but we have very limited data. And these are only the active registries which are there across the globe as of now. So we have a US-based National Transplant Pregnancy Registry, National Transplant Pregnancy Registry in United Kingdom, European Dialysis and Transplant Association Registry, and Australian and New Zealand data. Aside from this, we don't have any other active registries. So whatever data which we are projecting, whatever the risk complications which we are projecting is only from these 4 registries which are still active. So coming to our case, we have a 25-year-old ESRD patient. She has diagnosed with CKD secondary to FSGS, and she's on maintenance hemodialysis for the past 6 months, and she received a live related kidney transplant, and she underwent a procedure, and her creat was stabilized at 1, and proteinuria was less than 200, and pressures were under control. She is on medications, tacrolimus, MMF, and prednisolone, and on Bactrim DS prophylaxis and atorvastatin. At 6 months post-transplant, she indicated her desire to start a family, and these are the questions she's having in her mind. So the first question she asked us is, can I become pregnant? So as we know that ESRD, the effect of ESRD on fertility and pregnancy, there is a decreased renal clearance of prolactin. Because of this, there is decrease in the pulsatility of GnRH, and decrease in the, there is inhibition on LSH and FSH. This causes anovulation. So there is decrease in chance of conception. And 70% of CKD patients have menstrual irregularities, and out of this, 50% have amenorrhea. So as soon as post-transplant, this hypothalamic pituitary gonadal axis is restored to normal within 6 months. So there is high chances of conception within the first 6 months, and ovulation is restored within few weeks. So always we should emphasize these patients with regard to contraception, aside from the emphasis on the compliance with immunosuppressive drugs as well as antibiotics and compliance to prophylactic drugs. So as I told earlier, in CKD, there's decrease in renal clearance of prolactin. This increased prolactin causes decrease in the pulsatility of LH and FSH. So this is a normal surge which we see. The normal surge is no longer present. So there is decrease in ovulation, and this causes anovulatory cycles. So post-transplant, everything is reversed within 6 months. So the next question she's asking is, when is my best time to become pregnant? When can I plan my pregnancy? So there is nothing called as an ideal candidate, but in one of the best scenarios, the normal to good kidney function. Ideal is more than 90 ml per minute, but normal to good kidney function, this is more than 60 ml per minute. It's not given in body surface area because there's based on 24 hours creatinine clearance, and the patient should not have any proteinuria ideally, and anything less than 500 is considered as acceptable. The patient should not have hypertension or a well-controlled hypertension, taking only a single drug with no target organ damage, and very low dose immunosuppression with allowed drugs. Allowed drugs in the sense MMF as well as mTORs are a no, big no, because there is increase in teratogenicity. And there is a huge debate on the timing of the transplant. Some say that 2 years is ideal. Some say that the better pregnancy outcome is after 1 year of a stable graft function. So the European best practice guidelines say more than 2 years, and the American Society of Transplantation say after 1 year, and whatever the decision should be individualized. Further continued, the ideal candidate, the patient should not have any rejection episodes in the recent past, and there are no recurrent UTI episodes, and there is discontinuation of all the teratogenic drugs for at least 6 weeks prior to the conception. When these things are feasible, then that is the right time to plan a pregnancy. So the next question she asks is, will my baby be okay, doctor? As we know, these pregnancies post-renal transplant, there is an effect on the fetal journey as well. There is increased risk of preterm babies. There is 13-fold higher risk, low birth weight babies, 12-fold higher risk, and small first gestational babies, 5-fold higher risk. And the mean gestational age, majority doesn't go to a full term, that is 40 weeks or beyond 37. And the mean birth weight is less, that is 2.4 grams versus the normal 3.5 grams. But there is no increase in perinatal mortality. So what are the predictors of preterm delivery and low birth weight? So if the mother is having a graft dysfunction prior to the pregnancy, if the mother is proteinuric, she is on MMF and it's an unplanned pregnancy, and she is already a pre-existing hypertension who is taking antihypertensive drugs prior to the pregnancy. She is a diabetic patient and she is of Black ethnicity. There are higher risk of having preterm deliveries as well as low birth weight. So when we see that there is an increase in live birth, that is 75% in post-renal transplant when compared to the general population. This is the data against the US population, that is 65%. This spurious increase is because of the false reporting of a positive outcomes and the differences in the definitions which they take regarding the live birth rates. Normally, CDC says that the live birth rate should be reported for 1,000 live births of the population against the population. But in the transplant scenario, we take the number of live births against the 1,000 transplanted female patients. So because of this discrepancy, it appears that there is an increase in the live birth rate, but recent in Medicare analysis in US has shown that it is comparatively less, it's only 53%. And you can see there is a higher incidence of preeclampsia, 31% against 3.8% of general population. There is increase of preterm deliveries, 51% against the 12.5% of the general population. But remember, there is no increase in neonatal mortality. There is also a decrease in the mean birth weight, that is 2.5. What is the significance is we need to emphasize that there is a chance of having a low birth weight baby, hence thus low number of nephrons, and there is a decrease in nephron endowment, increase in the risk of cardiovascular disease in their in future in the babies who are born to a pregnant lady post-renal transplant. So the next question she asks, can I take
Leave the meeting.
Can I take my usual medication? So we have calcineurin inhibitors. The CNIs are generally considered to be safe, but there is increase in the risk of preeclampsia, low birth weight, IUGR, and small first gestational age. And there is a reporting saying that there is an incidence of developmental delay in 16% of the children who are exposed to CNIs during their intrauterine period, in utero exposure to CNIs. And during the pregnancy, because of the dilution, 20 to 25% dose elevation of CNI is normally prescribed to maintain the CNI levels. How often we should monitor the CNI levels? During the first and second trimester, it is bi-weekly monitoring. During the third trimester, it is weekly monitoring, and repeat the levels within a week postpartum. Next is corticosteroids. Corticosteroids, though they consider as safe, when the levels are more than 20 grams per day, there is increased risk of fetal adrenal immunosuppression, thymic hypoplasia, and cleft palate. And in the mother, there is increased risk of premature rupture of membranes and hypertension. And ESA is also considered as Cat C. It is considered as category C drug, but as a fetal liver, as we are aware that it doesn't cause activation of the active moiety, so it is considered to be safe in pregnancy, but never cross the dose of more than 6 milligrams per kg. Routine we give around 2 milligrams per kg. Don't give at this high doses, so which can cause neonatal leukopenia. MMF is an absolute contraindication, and the mother should be off this medication for 6 weeks prior to the planning of conception, because MMF increases the risk of spontaneous abortions and congenital malformations. And there are increase in limb and facial anomalies like microtia, hypoplastic nails, shortened fifth finger, cleft lip, palate, congenital diaphragmatic hernia, and heart defects. And if it is an unplanned pregnancy and it is in the first year of transplant, decision should be individualized after counseling with regards to malformation, whether it should be terminated or to be continued. That should be left to the mother, and we can't take a decision on their behalf. Sirolimus has very limited data. It should be stopped 6 weeks prior to conception. Rituximab, ATG, belatacept is contraindicated. So this is the list of the drugs which are usually considered as safe. Aza is considered as safe, azathioprine at 2 mg per kg. Cyclosporin is considered as safe, but it requires an increased dosing more than 30% of the pre-pregnancy levels, and more frequent monitoring is required for cyclosporin and tacrolimus. Steroids are also considered as safe, and see that the patient is in less dose of steroids, that is less than 20 grams. Avoided, MMF should be avoided, mTOR should be avoided, rituximab and Similac should be avoided. So the next question she asks, if I plan a pregnancy and if everything goes well, will my kidneys be okay? So the answer to this is, there is no difference in graft failure. There is no increase graft failure in pregnant kidney transplant recipients versus the non-pregnant kidney transplant recipients. The difference is not significant. And there is a slightly increased risk of graft loss if the mother is hypertensive, if there is a proteinuria, or if the creat is more than 1.4. So what is about the risk of rejection during the pregnancy or post-pregnancy? So rejection is also uncommon, and meta-analysis has shown the incidence is only 4.2%. And timing of rejection is unknown. Because of the limitation of the data which is available, we don't know what are the risk factors and what is the risk for the rejections, risk for graft loss, etc. And this emphasizes the importance of documentation of pregnancies post-renal transplant. And who are at risk of rejection? Patients with high pre-pregnancy serum creat, that is more than 1.4, history of rejection before the pregnancy, and changing levels of immunosuppression, these people are considered as high risk. So how we are supposed to manage a rejection if you are the pregnant lady is having a rejection? So if she is in the first trimester, definitely take the risk and do a biopsy. And how do you treat it? By high dose steroids. And patients do respond to high dose steroids. If it is an antibody mediated rejection, nothing much can be done. And you can't take ATG, basiliximab, alemtuzumab, and IVIG are contraindicated post pregnancy during the pregnancy phase. So if the patient is presenting to us with elevated renal parameters in a post-renal transplant, these are the things which we are supposed to look into: pre-renal causes and the post-renal causes. In pre-renal causes, we should see the normal physiological return to pre-pregnancy levels in third trimester. The creat should be normalized. It could be because of hypoperfusion, it could be because of preeclampsia, could be because of CNI toxicity, urinary tract infections, viral infections, or acute rejection. Post-renal obstruction. How do you differentiate between a routine physiological hydronephrosis from structural obstruction? Is ask for an ultrasound and ask if they can see the jets, ureteric jets, that is emptying of the urine into the bladder during voiding. If it happens, it is because of physiological reflex, and if it is not there, it could be an obstruction, structural obstruction. So what is the effect of the pregnancy on the graft? According to the National Transplant Pregnancy Register of USA, predictors of long-term graft loss are independent of the immunosuppression, hypertension, and preeclampsia. So low pre-pregnancy graft function, that is more than 1.5, rising creatinine during pregnancy, and black movement post-pregnancy. All these are risk factors for graft loss. And the other important thing is postpartum restoration of immunity. Normally, the placenta acts as a sieve for all this, and placenta is helpful for development of tolerance. So once postpartum, there is delivery of the placenta, there is restoration of the immunity, reactivation of T cells, and increased risk of rejection. But this doesn't happen because the estrogen, increased estrogen levels, as well as interleukin 10 levels will take care that rejection doesn't happen. And studies of kidney transplant patients with pregnancy and without pregnancy, there is no difference in the outcome. So the long-term graft survival depends upon the pre-transplant creatinine, the rejection episodes prior to the pregnancy, and the proteinuria prior to the pregnancy. And there is no increased risk of graft loss, and there is no increased risk of rejection as far as the data which is available, from the data which is available. So this says the frequency, this slide gives an idea regarding the frequency of monitoring, how often we are supposed to monitor. So kidney transplant patients doesn't have any specific guidelines. We just follow the guidelines based on staging of the CKD, stage 1, stage 2, stage 3, and stage 4. So if the patient is in stage 1, based on the GFR, that monitoring should be 2 to 4 weeks. From stage 3 on, it should be 1 to 2 weeks. So what are the analysis which we should ask for these patients? You should ask for complete urine examination, urine culture, and routine electrolytes, albumin, the creatinine clearance, urea, uric acid, and 24 hours urine protein. Culture should be done every 1 to 4 weeks. And imaging, repeat renal ultrasound should be done if not performed in the previous year. And routine other investigations are nutritional parameters, vitamin D, B12, folates, albumins, and total proteins. Drug levels, as I told you, they should be done at least twice a month at pregnancy start and at least monthly afterwards. So they should have more frequent monitoring, that is at least once in 1 month. More frequent monitoring. Culture also, urine culture also should be done once in 1 month. Sorry, my slides it's not moving. Yeah. So the renal monitoring, yeah. The renal monitoring, 24 hours creatinine clearance should be done every 4 weeks. Renal 24 hours urine protein every 4 weeks. Complete urine examination every 4 weeks. Urine culture every 4 weeks, and drug level testing based on the trimesters. In the first and second trimesters, bi-weekly. In the third trimester, once in a week. Once in a week, and then postpartum. So next, the mother will be asking, will I be okay? So risk of maternal complications, there is hypertension and preeclampsia, gestational diabetes, and infections. So hypertension, preeclampsia risk is 6-fold higher risk due to endothelial injury. And the normal physiological fall in BP affected in transplant recipients doesn't occur. So what is our target is, ideally you should maintain the blood pressure less than 130/80. Acceptable is 140/90. So the other biggest question is, how do we differentiate preeclampsia in these transplant patients from having a proteinuria and hypertension prior to the transplantation? The best marker is available biomarker is take SFLT1 by PIGF ratio. If it is more than 85, it says it is preeclampsia. If it is less than 85, it could be because of proteinuria from the native kidney disease or hypertension or chronic allograft nephropathy. So these are the drugs which are considered safe: alpha methyl-dopa, nifedipine, and labetalol. Second line are beta blockers, clonidine alpha blockers. Don't give ACEs, ARBs, or short-acting nifedipines. So gestational diabetes, there is no increase in risk. The incidence is only 8%. As again, I say, there is very less data to say, to pinpoint and say that there is increase in risk of gestational diabetes or any other comorbidities because of the limitation of entries into this registries. So if you are having a proteinuria in the kidney transplant patient, low dose salicylate, that is aspirin, should be given and start as early as possible. As the test is positive, start as early as possible to favor the placentation. Or you can start in second trimester if there is a past history of miscarriage. And avoid the protein-rich diets to decrease the hyperfiltration injuries to the kidney. And if you're planning on albumin infusion, try to avoid it. So infections, there is increased risk of UTIs in the pregnant mother, and antibiotics, the duration of therapy should be 2 weeks, and the total and prophylactic antibiotics should be continued for the rest of the pregnancy. And normal antibiotics which are used are nitrofurantoin and cephalexin. and monitoring monthly urine culture should be done. CMV prophylaxis is routinely not recommended, and diagnosis of fetal CMV is done by culture of amniotic fluid. So if the mother says that, okay, doctor, I have tried and I am unable to conceive, can I try assisted reproduction techniques? The answer is yes, she can try an assisted reproduction techniques. There is no absolute contraindication, but there is a slightly increased risk of preeclampsia, gestational hypertension, increased risk of ovarian hyperstimulation syndrome, and premature rupture of membranes. And always plan for a single embryo transfer, because multiple gestations are associated with higher complications when compared to singleton pregnancies. So the next question, if I conceived and everything goes well, do I need to have a C-section? No. Vaginal delivery is the preferred route of delivery. Even though the graft is there, the vaginal delivery doesn't cause any obstruction to the or any damage to the ureter during the delivery. And C-section is indicated only for obstetric indications. And if the lady doesn't go into labor, you can wait up to 38 to 42 weeks if there are no obstetric complications. There is no indication for early induction of labors. And stress dose steroids should be given to the mother during the labor. So the next question, can I breastfeed my baby? It's a big yes. Yeah, she can breastfeed her baby. And if the patient is on prednisolone, azathioprine, CNI, she should not be discouraged. She should be encouraged to breastfeed the baby up to 6 months. But it should be at the discretion of the mother. And if she is on MMF, mTOR or Beltaceb, breastfeeding should be avoided. The next question, doctor, I'm not ready for pregnancy. What are my contraception options? So if the mother is not prepared, if the transplant patient is not prepared to become pregnant, these are the contraception options. So advice for all the sexually active women before transplant and immediately post-renal transplant, no ideal contraception. Barrier contraception is not advised because of risk of failure. And IUD, IUD should not be withheld. Before placing the IUD, screen for gonorrhea as well as chlamydia. There is no increased risk of pelvic inflammatory disease. But the recommendations of American Transplant Society and CDC says that oral contraceptive pills are contraceptions of choice if there are no contraindications. If the transplant patient has completed the family, advise tubal ligation, because the fertility is restored within 6 months. There is chance of unwanted pregnancy, so advise tubal ligation. So how is kidney transplant patients with multiple gestations, how does they fare? We should not interrupt the multiple gestations in kidney transplant, and but we should intensify the follow-up, and we should involve the team who are experts in handling multiple gestations. So what about the simultaneous kidney pancreas transplant patients who want to become a mother? So the pregnancy outcomes in kidney transplant without the diabetes is better when compared to a simultaneous pancreas kidney transplant patient. In patient who is diabetes alone, diabetes plus only kidney transplant. So this has a best outcome, followed by this simultaneous pancreas kidney transplant, followed by kidney transplant without diabetes. Low birth weight and small for gestational age prevalence is more in simultaneous pancreas kidney transplant versus kidney transplant patients. And the pancreas kidney transplant mothers should be monitored very closely every 2 weeks, not like 4 weeks, which we do in kidney transplant patients. So the other question, we see a lot of donors, and as we see majority of donors are females, they ask, what are the complications I would have as I haven't completed my family? I want to donate a kidney. So there is increased risk of preeclampsia and gestational hypertension, but there is no difference in the neonatal outcomes or neonatal mortalities. To summarize, the hypothalamic gonadal axis is restored in 6 months, but ovulation is restored within few weeks, and we should emphasize on the need of contraception. So these are the ideal pre-pregnancy prerequisites. At least 6 months post-transplant, ideally is more than 1 year. Stable allograft function with creat less than 1.4, no recent episodes of rejection, blood pressure less than 140/90, no or minimal proteinuria, prednisolone less than 15, and SR less than 2 milligrams per kg per day. Stop MMF and mTOR 6 weeks prior to conception. And there is increased incidence of preterm babies, low birth weight, and small for gestational babies, but there is no increase in neonatal mortality. There is increased risk of preeclampsia when compared to general population. There is no increased risk of rejections versus in the pregnant ladies versus kidney transplant without pregnancy. IUD should not be contraindicated, but oral contraceptive pills are preferred if there is no contraindication. Kidney transplant patients can undergo assisted reproduction techniques, but plan a single embryo transfer. And pregnancy after simultaneous pancreas kidney has less favorable outcome than a kidney transplant patient. Post-renal renal donation, there is increased risk of preeclampsia and gestational hypertension. And normal vaginal delivery can be tried unless there is an obstetric contraindication. Spontaneous labor can be waited for, need not induce the patient, and breastfeeding is routinely encouraged. Take home message: all the transplant patients who want to be a mother, they should be encouraged, and they should be encouraged to go through assisted reproductive techniques if required, and they should be encouraged for normal vaginal delivery, for breastfeeding, and they should be given proper counseling. And we should enhance our knowledge so that we can help them in the best possible way. Thank you. These are my references.
Yeah, thank you, Bhavya. Thank you for a comprehensive presentation. As we have passed our time, so I will not delay the next speaker, but a few points. One is, actually cesarean sections are much more common than vaginal delivery in these mothers. And if there is a vaginal delivery, the mother, the obstetrician should be aware where the ureter is placed actually. There should be idea about the allograft and the ureter, and they should not try any instrumentation without being aware of where is the placement of the ureter. So the urologist or the transplant surgeon should guide them if there is a vaginal delivery being conducted. And finally, you said ATG and basiliximab is not contraindicated. It's just that there is very limited data. So transplant rejection, which is rare though, if there is any rejection, you can use methylprednisolone. If there is an AMR, biopsies are very safe in pregnancy. You can even use plasmapheresis. But if required, steroid resistant or other forms of ACR, you can think of ATG, but it's not contraindicated. The drug has not been assigned according to FDA. So that's it. And tacrolimus levels are falsely high. Everybody should be aware during pregnancy. If you develop a asymptomatic bacteriuria, you treat for the whole term of pregnancy. Proteinuria is important, but proteinuria has not been very important in patients with, let's say, a recurrent membranous nephropathy or things like that. In hypoalbuminemia is important if you know if there is a recurrent disease in these patients. Of course, transplanted mother with recurrent diseases, pregnancy itself is a challenge and there is very little history. Go ahead for transplant after 1 year. Don't wait for 2. And also, when you are considering transplant, see that all antiviral prophylaxis are over. Nothing is left. If the mother has had a CMV infection and she is again on a treatment or prophylaxis, reprophylaxis for antiviral for ganciclovir or valganciclovir, don't consider pregnancy in them. So that's another point. When you say these are my checklist, the one checklist should be that there should be no antiviral prophylaxis going on. Prophylaxis or treatment, of course, you will not think of pregnancy. Thank you. Thank you very much. I think, Sindhu, you can go ahead for the next presentation.
Okay, ma'am. First of all, I thank Dr. Bhavya, ma'am, for your very lucid, clear, and comprehensive presentation. And Urmila, ma'am, thank you for your valuable presence. And any questions, please place in the chat box. We'll take questions at the end of the session. Now, moving on to the next session, the session number 2, UTI in pregnancy, moderator Jikki ma'am and presenter Dr. Sailaja ma'am. Sailaja ma'am, can you please share your screen? Meanwhile, I'll introduce the moderator of the session, Jikki ma'am. She does not require any introduction in this group. Jikki ma'am has done her MBBS from Keelpok Medical College, Chennai, MD from Kurnool Medical College, DM from Osmania Medical College, Hyderabad. She is a retired additional DME and principal, Kurnool Medical College, Andhra Pradesh. retired professor and HOD of nephrology, Kurnool Medical College. And her awards are, she was awarded Fellowship of ISN in 2019, Certificate of Commendation from Government of Andhra Pradesh in 2014, 21 and 22. Additional accomplishments include President Women in Nephrology AP chapter. Also, she's appointed as a President of AP Society of Nephrology in the recent 2022 Guntur conference. Over to Jiki ma'am for the introduction of the presenter.
Thank you, Doctor, for the good introduction. And good morning, all. I feel privileged to introduce my student and a junior colleague in the past, Dr. Sailaja. She did her MBBS and MD from Kurnool Medical College and DM from Gandhi Medical College. And she worked as assistant professor nephrology in KMC, that is Kurnool Medical College, for 3 years. And then presently, she is now into private practice in nephrology at Kurnool. The topic she's going to talk on is urinary tract infection in pregnancy, which seemingly very simple, but it is not so. It is very much complicated and may lead to even acute kidney injury in pregnancy. Over to Dr. Sailaja.
Thank you, ma'am. Good morning, everyone. Today, I am going to talk on UTI in pregnancy. Today, I will discuss about pathophysiology of UTI in pregnancy, classification of UTI, epidemiology of urinary tract infection in pregnancy, symptomatic versus asymptomatic UTI, and maternal and fetal complications of UTI, and approach to management of UTI. UTIs are the most common bacterial infections during pregnancy, and it is responsible for 3.5% of antepartum admissions in pregnancy. The incidence of bacteriuria in this population is only slightly higher than in non-pregnant women, but untreated bacteriuria during pregnancy is associated with significant maternal and fetal morbidity. Timely intervention gives excellent maternal and fetal outcomes. With this background, I will go into the details of UTI in pregnancy. In clinical practice, we will come across 3 terms in UTI. One is recurrent urinary tract infection, and relapsing UTI, and reinfection. Recurrent urinary tract infection is defined as, in non-pregnant women, it is defined as 3 infections in the previous 12 months or 2 episodes in the last 6 months. But in pregnancy, it is defined as more than 1 urinary tract infection before or during pregnancy. Relapse. Relapse is a recurrent urinary tract infection where the organism that was previously treated persists in the urinary tract for more than 2 weeks after completing the treatment. Actually, reinfection is the true recurrence. It occurs only after sterilization of urine with no organism, with an organism originating from the outside of the urinary tract, either a new bacterial strain or a strain previously isolated that has persisted in the colonizing flora of the gut or vagina more than 2 weeks after treatment. The combination, now we will discuss about the pathophysiology of urinary tract infection in pregnancy. The combination of mechanical, hormonal, and physiological changes during pregnancy responsible for significant changes in the urinary tract, which results in increased incidence of bacteriuria during pregnancy. So 90% of the pregnant women have dilatation of the urinary tract with hydronephrosis, which is called hydronephrosis of pregnancy. Partly, this is caused by high circulating progesterone levels, which causes smooth muscle relaxation, which results in decreased ureter peristalsis and urinary stasis. And it is also partly caused by compression of enlarged ureter on the urinary bladder, which increases intravesical pressure, which results in vesico-ureteric reflex, thereby increases the risk of ascending infection and responsible for pyelonephritis in pregnancy.
And the additional risk factors which are associated with the pregnancy are aminoaciduria and glycosuria and alkaline urinary pH and decreased immunity in pregnancy associated with which encourages the bacterial growth in urine, and short urethra in females and difficulty with hygiene due to distended pregnant belly increases the frequency of UTI in pregnancy. This is the class. Now we will discuss about the classification of UTI. It is based on the clinical presentation. This is a level of infection affecting the urinary tract, urethritis, cystitis, and pyelonephritis, and infection reaching the blood, urosepsis, and male genital glands. Actually, this classification includes the classification of UTI in both males and females. So male genital glands also included in this classification, and this is the classification of UTI based on the grade of severity. Grade 1 is low severity, which includes only cystitis. Grade 2 is pyelonephritis with moderate symptoms. Grade 3 is pyelonephritis with severe symptoms. Grade 4 is urosepsis with SIDS, and grade 5 is urosepsis with organ dysfunction, and grade 6 is urosepsis with organ failure. And another classification based on the risk factors: urinary tract infection with no risk factors, and UTI with the recurrent urinary tract infection risk factors, and UTI with the extra urogenital risk factors, and nephropathic risk factors, UTI with the urological risk factors, and UTI with catheter risk factors. And another classification is based on the susceptibility of the organisms to the routine antibiotics. They are susceptible. In the first grade is first one is susceptible to regular antibiotics, and reduced susceptibility and multi-resistant. Here we can see the by including all the different parameters, UTI in pregnancy can be classified as follow. CY means cystitis, 1 is grade 1 severity, R means recurrent risk factors with the E. coli being the pathogen. A is it is susceptible to regular antibiotics. So the another classification of UTI is upper urinary tract infection and lower urinary tract infection. Upper urinary tract, if patient has symptoms suggestive of cystitis, it is regarded as lower urinary tract infection, whereas the symptoms suggestive of pyelonephritis characterized as upper urinary tract infection. And another classification is asymptomatic bacteriuria and symptomatic bacteriuria. First, we will discuss about the epidemiology of urinary tract infections. Urinary tract infections are most common bacterial infections during pregnancy. Studies have shown that the frequency of asymptomatic bacteriuria in pregnancy is between 2% to 18.5%, which is almost similar or slightly higher than asymptomatic bacteriuria in non-pregnant population. And on the other hand, cystitis complicates around 1.3% of pregnancies, and pyelonephritis occurs in 2.2 to 4% of the pregnancies. And the prevalence of UTI in India ranges from 3% to 4%, which includes both the asymptomatic bacteriuria and symptomatic bacteriuria. But in India, no regular screening is done for presence of symptomatic urinary tract infection or asymptomatic bacteriuria in pregnancy, especially at primary healthcare center level and community healthcare center and sub-district hospitals in India because of lack of facilities for microbiological diagnosis. They are available only at district hospitals and tertiary care centers. Because of this non-availability of diagnostic facilities leads to delay in the diagnosis and also impose a financial burden on the individuals. And the greatest risk factor for the pyelonephritis is asymptomatic bacteriuria. In one study, they have found the incidence of pyelonephritis is around 24.8% in pregnant women with asymptomatic bacteriuria who were untreated, whereas the incidence is only 3.2% among the patients who were treated. So even in another study, they have found 30% of the pregnant women with bacteriuria developed pyelonephritis compared to only 1.8% of those pregnant women without bacteriuria. And the prevalence of UTI in pregnancy is closely related to low socioeconomic groups. The other risk factors for UTI in pregnancy is underlying diabetes mellitus and recurrent UTI in pre-pregnancy level, and anatomical abnormalities of urinary tract, higher parity, older age, sickle cell disease, and age less than 50 years at first UTI have also been thought to be risk factors. But there is controversy about older age and sickle cell disease and multiparity. Risk factors associated with recurrent UTI, others are frequency of intercourse and certain sexual behaviors and secretory status of certain blood groups. The causative agents are similar to general population. E. coli accounts for the majority of urinary tract infection, as high as 60 to 80%, and remaining are Klebsiella, Enterobacter, Proteus species, and Enterococcus. They are infrequently associated with UTI, especially uncomplicated and pyelonephritis. Candidal urinary tract infections are especially common in immunocompromised patients and those with indwelling catheters, and very infrequent cause for UTI in pregnancy is group B streptococcus and mycoplasma and ureaplasma. When they are very rare, but they have significant role in association with the chorioamnionitis and neonatal disease. We will discuss these things in later slides. This is the percentage distribution of etiological agents for urinary tract infection, both outpatient and inpatient. Both in both the conditions, E. coli being the most common organism, followed by Klebsiella proteus, and Candida is most common in patients. Now we will discuss about symptomatic versus asymptomatic UTI. This distinction is mainly based on the presence of classical symptoms of UTI like dysuria, frequency, urgency, and clinical examination findings. Asymptomatic bacteriuria is marked by absence of symptoms and the culture from a single midstream voided urine sample yields colony count more than 10 to the power of 5 per ml. If it is a bladder catheterization sample, 100 colony forming units is enough. Asymptomatic bacteriuria incidence is similar to non-pregnant population. But the bacteriuria during pregnancy has a greater tendency to progress to ascending infection than in the non-pregnant woman. This is associated with the increased risk of adverse fetal outcomes. Now we will discuss about the maternal and fetal complications of asymptomatic bacteriuria. Maternal complications are hypertension, preeclampsia, anemia, chorioamnionitis, symptomatic acute cystitis, acute pyelonephritis, whereas fetal complications are IUGR and intrauterine death, low birth weight, and prematurity. First, we will discuss about the association of urinary tract infection and preeclampsia. One large case control study from UK found that they have compared women with the UTI, pregnant women with the UTI and without UTI. The odds ratio of preeclampsia increased with the UTI and antibiotic administration, but they do not found any increased odds ratio with the respiratory tract infection. That indicates there is a role of UTI in preeclampsia. And the same association was also found in secondary analysis of WHO Global Survey on Maternal and Perinatal Health Survey. It is also found increased risk of preeclampsia in pregnant women with UTI. Though the exact mechanism is not known, but some authors hypothesize that urinary tract infection in childhood leads to renal scarring, but this may be asymptomatic during childhood. Consequences become symptomatic during pregnancy. And another association is urinary tract infection with the chorioamnionitis. There is a strong association between group B streptococcus bacteriuria and chorioamnionitis. This is less common, but is common. It causes chorioamnionitis by releasing beta hemolysin and cytolysin. They causes pores. They causes pore formation in the placentofetal barrier. Even rare organisms like ureaplasma and mycoplasma is also associated with increased incidence of chorioamnionitis. The another association is preterm delivery. This is also increased with group B streptococcus bacteriuria by increasing the mediators of inflammation such as arachidonic acid, phospholipase A2 and prostaglandins. These causes cervical softening and an increase in the myometrial free calcium content, which increases the uterine contractions and results in preterm labor. There is another association with neonatal group B streptococcal disease. Because of this heavy colonization of genital tract with group B streptococcus at the time of delivery or rupture of membranes, this reaches the neonate through the vertical transmission and may manifest as pneumonia or sepsis in the neonate. So, for these patients in subsequent pregnancies, treatment should be initiated at the time of labor or rupture of membranes with appropriate intravenous antibiotics for the prevention of early onset of neonatal group B streptococcal disease. Another association is neonatal UTI. There is evidence suggesting an association between maternal UTI during pregnancy and neonatal UTI. Even two studies also compared neonatal UTI is increased in patients who have neonate mother who have UTI in pregnancy. Now we will discuss about symptomatic urinary tract infections. First is cystitis. Cystitis is infection of the urinary bladder which presents with dysuria, frequency and lower abdominal pain or suprapubic pain without fever, and pyuria may not be present. And in these conditions, systemic symptoms are absent, like fever, rigors, and chills, vomitings are absent. Up to 30% of the patients with the asymptomatic bacteriuria later develop symptomatic cystitis. Now, pyelonephritis. Pyelonephritis is an infection of upper urinary tract in which patient may present with fever, tachycardia, dysuria, abdominal pain, nausea, vomitings, and tenderness over costovertebral angle on the side affected, but it is more common on the right side. It can be complicated by septic shock, renal abscess if not diagnosed and not treated properly, and it may cause transient renal insufficiency, ARDS, and pyelonephritis can also lead to increased hospital stay and medically indicated preterm delivery. Now, what are the long-term effects of pyelonephritis? There are some studies showed that patients with persistent bacteriuria during pregnancy may have chronic pyelonephritis or chronic renal insufficiency. But more recent data showed that asymptomatic bacteriuria in pregnancy revealed no residual renal function impairment. So, and renal failure rarely results from recurrent urinary tract infection in the absence of obstruction. So now we will discuss about screening. Screening should be done only with the urine culture. It should be advised according to the NICE guidelines. It should be advised at around 10 weeks. 10 weeks. And another guidelines showed around 12 to 16 weeks gestation, we can advise screening. So urine culture should be performed routinely at the first antenatal visit. And if if culture is positive, we have to advise the second sample also. And if patient is confirmed with the second sample, we have to treat that patient, and we have to advise the urine culture every month till the date of delivery. And dipstick testing should not be used to screen for bacterial UTI at the first or subsequent antenatal visits. Why we will discuss in later subsequent slides. Now we will discuss about the approach to patient management. So UTI symptoms are usually mimicked with other common discomforts of the pregnancy due to physiological changes. They are nausea may be confused with high levels of HCG levels, and the frequency of urine may be confused with pressure effects of urinary bladder by gravity uterus, and patients with this. In these situations, along with the history, clinical examination is very, very important. Clinical examination with relevant investigations is important to identify the UTI in pregnancy. During the examination, we have to assess for fetal status also. For minimizing the contamination, suprapubic aspiration is the gold standard, and straight catheterization is second best. But both these procedures are invasive and laborious. So the clean catch midstream urine technique is non-invasive and yields colony count that correlate well with the samples collected using the other two methods. So cleansing procedures used in this method have no added benefit, so they are not routinely advised. Interpretation of results should bear in mind the collection technique should be specified on the requisition form, whether we are sending a midstream urine sample or suprapubic aspiration sample. So we have to look for physical properties of the urine. If patient is having cloudy urine sample, that indicates pyuria. If urine color is red, that indicates hematuria. If patient urine sample is having a pungent smell, it is characteristic of UTI. Other parameters we will test in urine analysis is nitrates. Presence of nitrates, they accurately predict the presence of UTI, but it is highly specific for nitrate reducing gram-positive or gram-negative bacteriuria in specific quantities, but it is not highly sensitive. And another one is leukocyte esterase, which is produced by neutrophils, may occur in pyuria. Leukocyte casts are more common with pyelonephritis than cystitis. And chlamydia and ureaplasma may be associated with pyuria, but negative urine cultures. So negative nitrate and leukocyte esterase can be used to rule out UTI in pregnancy, but they are not these nitrates and leukocyte esterase have very high high sensitivity. Sensitivity rate is very low, so they are not used for routine antenatal investigation. And in microscopic examination, if we find squamous epithelial cells, that indicates contaminated urine sample. If leukocyte casts are present, they indicate pyelonephritis, and the presence of triple phosphate crystals, they can be normal finding or may be associated with protease species which grow in the alkaline urine. Okay. And another one is gram staining. If we find more than 5 bacterial cells per high power field, that correlates with more than 10 to the power of 5 colony forming units on culture, that indicates UTA. But this is very insensitive, because this does not detect bacteriuria in low ranges. But it is useful in patients with acute pyelonephritis, invasive UTA, where immediate information on the etiology is needed to start the antibiotic treatment. Urine culture, I have already told. For midstream, clean catch midstream urine, colony count more than 10 to the power of 5 colony forming units per ml is significant, whereas for bladder catheterization, colony count 100 per ml is significant. Now we will discuss about role of complete blood count. It is WBC count is usually elevated in in case of pyelonephritis, and even in some situations in cystitis, but it cannot localize. It does not localize the infection. Its routine use for uncomplicated UTA is therefore not recommended. In patients with a complicated UTA, it may be necessary to evaluate for severe infections such as sepsis. And procalcitonin was significantly higher in pregnant women with UTA than in healthy pregnant women. Imaging, ultrasound is ultrasound. We can do it for routine indication in pregnancy, but not for the assessment of asymptomatic UTA. But it is useful if we are suspecting pyelonephritis or any if we are suspecting any obstructive etiology or abscess. Ultrasound can also be document kidney size and scarring. This can guide percutaneous nephrostomy if indicated in case of renal abscess. And another imaging technique we can use in pregnancy is MRI. MRI is especially useful in situations where we can suspect perinephric abscess, emphysematous pyelonephritis, and renal papillary necrosis. This application is more relevant in patients with urosepsis. Now we will discuss about treatment of asymptomatic bacteriuria. If we left untreated, asymptomatic bacteriuria can lead to acute pyelonephritis in 30 to 50% of the cases. So treatment of bacteriuria with colony forming colony count more than 10 to the power of 5 in pregnancy using appropriate antibiotics is accepted and recommended strategy. So they have this Cochrane review recommended that the choice of antibiotic should be made on the basis of cost, local availability, side effects in the selection of best treatment option, and this antibiotic should have good maternal and fetal safety profile, excellent efficacy, and low resistance rate in given population. These are the treatment regimens used for asymptomatic bacteriuria and cystitis in pregnancy: nitrofurantoin, amoxicillin, co-amoxicillin, cephalexin, and phosphomycin, and trimethoprim. But trimethoprim we have to avoid in first trimester and in term, because trimethoprim decreases the folate synthesis, which is mainly needed to prevent a neural tube formation. Even in term also, it displaces the bilirubin from the binding site, increases the neonatal jaundice. This nitrofurantoin, we have to avoid it in G6PD deficiency. The duration we will discuss in the next slide. We have to give the treatment standard 7-day regimen. There is no role of a single dose regimen, which can be used in a non-pregnant woman. But in pregnancy, we have to give a standard 7-day regimen. Currently, there is no evidence existing comparing 3 days, 4 days, or 5 days regimen with the 7 days. Now we will discuss about treatment of pyelonephritis. Pyelonephritis some women may have mild symptoms. They can have close follow-up with the outpatient treatment. Now we will discuss about what are the indications for outpatient treatment. Patients should be less than 24 weeks, and these patients should be healthy and able to maintain, they should maintain adequate hydration. They should not have excessive fever, severe anemia or vomitings. They should not have recurrent upper urinary tract disease, and they should not have signs of sepsis, including tachypnea, tachycardia, rigors or hypotension, immunocompromised patients, and significant medical conditions such as diabetes and previous renal disease, and a history of substance use abuse, concurrent preterm labor, and uncertain diagnosis. In the absence of all the above factors, we can treat the patient on OP basis with close follow-up. If pyelonephritis is after 24 weeks of gestation, the patient has to be admitted and we have to maintain adequate hydration, and we have to give IV antibiotics until they have been fever-free for 48 hours. Then we have to switch it to oral treatment. It should be continued for 10 to 14 days. So here also antibiotic, they have studied various antibiotic regimens. They found there is no significant difference in relation to cure rate, recurrence, incidence of preterm delivery or admission to neonatal intensive care unit, need for antibiotic change or incidence of prolonged pyrexia for various antibiotic regimens in most of the included studies. So these are the antibiotics we can use it in symptomatic UTA, pyelonephritis, ceftriaxone 1 to 2 grams IV or IM. IM we can give in outpatient pregnant women. Piperacillin tazobactam 4.5 grams IV every 6 hourly, cefepime or imipenem with cilastin. Ampicillin, there is increased drug resistance with ampicillin, but ampicillin urinary levels are very high. So in spite of increased resistance, ampicillin is the good drug in symptomatic UTI patients. Aminoglycosides are usually contraindicated in pregnancy in view of increased incidence of ototoxicity. And some special notes on drugs. As we have already discussed, trimethoprim we should not give in first trimester and after 32 weeks of gestation, because this inhibits the folate synthesis and it causes neonatal jaundice at the time of delivery. So we should not give before after 32 weeks of gestation. Quinolones, in several studies they have found increased incidence of major malformations or fetal musculoskeletal defects, spontaneous abortions, prematurity, intrauterine growth retardation, and postnatal disorders. Ampicillin, it has a particularly active against enterococcus. I have already told it has high levels of urinary concentration. So even though emerging in resistance, it can be used. Cephalosporins are generally safe during pregnancy, but the high protein binding capacity of ceftriaxone may displace the bilirubin if given a day prior to the delivery, predisposing the neonatal jaundice, especially in premature infants. Okay, in some studies, they have found cephalexin associated with major defects, but in other studies found there is no significant teratogenicity. So nitrofurantoin should be avoided in G6PD deficiency patients. Management of urosepsis. Urosepsis, the treatment usually continued for antibiotics should be continued for 14 to 21 days in urosepsis. If patients fails to respond to treatment after 72 hours, we have to evaluate for the underlying urinary tract obstruction or abscess, which necessitate drainage. Apart from the antibiotic therapy, other measures must be undertaken to avoid the risk of septic shock. Hemodynamic support is important. The goal is to achieve and maintain adequate tissue perfusion. IV fluids are administered initially and vasopressor medication if IV fluids fails. So we already discussed, if there is no response even after 72 hours, we have to suspect bacterial resistance to the antibacterials used and renal stones, perinephric abscess, and congenital urinary tract abnormalities. In this situation, we have to change the antibacterial agent and they should undergo imaging for the underlying malformations. In some studies, they have used IVP also, even though it has minimal, it has radiation exposure. To minimize the radiation exposure to the fetus, they have taken only one exposure for 20 to 30 minutes. 30 minutes. So MRI is also have a role if we are suspecting underlying perinephric abscess or renal papillary necrosis. So how to, there are pyelonephritis in pregnancy increases the risk of pyelonephritis in the same pregnancy or in the subsequent pregnancies. So how to prevent recurrent urinary tract infection in pregnancy is, one is postcoital prophylaxis, who have history of frequent UTIs before the onset of pregnancy, even UTIs during pregnancy also. For subsequent pregnancies, we have to advise postcoital prophylaxis. So this Cochrane review showed that daily dose of, in patients who have pyelonephritis, they should be treated with a daily dose of nitrofurantoin. It should be combined with close follow-up, monthly urine culture and sensitivity report. We have to follow to prevent further recurrence of pyelonephritis in same pregnancy. Apart from pharmacological interventions, non-pharmacological like cranberry products used in the past for the prevention of recurrent urinary tract infection, but best approach is currently not known. Their role in prevention is not known. Summary, asymptomatic bacteriuria in pregnancy predisposes women to pyelonephritis and cystitis. These urinary tract infections in pregnancy are associated with the chorioamnionitis, preeclampsia, low birth weight, and neonatal infection. Screening for bacteriuria with urine culture is recommended early in the pregnancy, between 10 to 16 weeks, or at first booking if later. The use of dipstick testing to screen for bacterial UTI at the first or subsequent antenatal visit is not recommended. Treatment of any bacteriuria with a colony count more than 10 to the power of 5 per ml in pregnancy with appropriate antibiotic is recommended. Treatment should be based on culture and sensitivity findings, especially for asymptomatic bacteriuria. For symptomatic UTI, empirical treatment with broad spectrum antibiotics with the activity against E. coli should be chosen on a background of cost, safety in pregnancy and availability. Long duration of treatment is better than single dose treatment. Thank you.
Congratulations, Dr. Sailaja. That was an exhaustive and extensive coverage of urinary tract infection in pregnancy. Congratulations.
Thank you, ma'am.
Thank you, Jiki ma'am and Sailaja ma'am. And over to the Hitashi ma'am for next presentation. The next presentation is pregnancy in nephrotic syndrome. Presenter is Dr. Sarath Josna ma'am. Sarath Josna ma'am, shall I introduce her ma'am? Hitashi ma'am? Okay, thank you ma'am.
Okay. Good morning, Dr. Sarath Josna. She has graduated from Andhra Medical College, Visakhapatnam, and then did her MD in Usmania. got nephrology training from Andhra Medical College. She has worked as assistant professor in Kurnool Medical College, currently working as associate professor at Government General Hospital, Srikakulam.
Extensive coverage.
She will be speaking on nephrotic syndrome in pregnancy. Nephrotic syndrome, though rare in pregnancy, it presents a diagnostic and therapeutic challenge for us. So it has to be differentiated from preeclampsia. And histological diagnosis is essential for specific management. And biopsy will be risky, especially in late stages of pregnancy. Let us hear to Sarath Josna how we manage nephrotic in pregnancy. Over to you, doctor. You have to unmute. Sarath Josna, you have to unmute. Not able to hear you.
Ma'am, Sarah Josna, ma'am, can you share your screen? Ma'am, are you there? Yes.
Yeah, she's there.
Ma'am, unmute yourself,
Unmute.
ma'am.
Please remove your headphone.
Somebody can help her.
It's not audible, ma'am.
Ah.
Remove your earphones, ma'am.
Am I audible?
Yeah, no.
Yes, ma'am.
Process and CNS. Today I am going to discuss about pregnancy nephrotic syndrome.
Voice is low.
Is it audible now, ma'am?
It is, ma'am. I think you have to share your screen, ma'am. Your
I
slides.
have shared the screen, ma'am.
It's not visible.
There will be a share screen option on the top, ma'am. Your
Yes, I
video
have
is.
screen, ma'am.
Ma'am, can you exit and share again? Stop sharing and share again.
Are my slides are visible, ma'am?
No, ma'am.
Yet share, ma'am. Just you click in the
I have
bottom. There is one
shared.
button. Is there? Share screen button.
Yes, I have shared. I pressed it.
Or Mr. Murthy.
Just please. Hello.
Yes, ma'am.
Is it audible, ma'am?
It is audible, ma'am, but your
I have shared.
lights are.
I have shared the screen, ma'am.
Okay. Do you need any?
It's not well.
Sindhu,
Slides,
otherwise,
ma'am, or Mr. Murthy, share her slides, ma'am.
Sindhu, otherwise you take the remote and share the slides of Sharad Jyotsna, madam.
Actually, ma'am, can you send the slides on the group, ma'am?
Okay, ma'am.
It
I
is
have
there.
already shared.
Shared.
Okay.
He has shared it.
Yeah,
Yeah.
it's come.
Yeah.
Sharad Jyotsna, madam,
Yes,
please
ma'am.
go to slideshow, madam. Slideshow.
Yeah, I am in slideshow mode only, ma'am.
Yes,
Yeah.
ma'am. They are visible, ma'am. You can start, ma'am.
Good morning. Today I am going to discuss about pregnancy nephrotic syndrome. While dealing with proteinuria in pregnancy, we have to think of 4 issues. One, either it is a new onset of renal disease in pregnancy, or it is a worsening of the pre-existing renal disease, which indicate either it is a progression of the underlying glomerular nephritis or relapse of the nephrotic syndrome. And another thing being preeclampsia during pregnancy, or it could be a preeclampsia superimposed on underlying kidney disease. Next. Here we are encountering 3 scenarios. In case 1, 27-year female who was diagnosed and treated for membranous nephropathy for 5 years ago. Her biopsy showed membranous nephropathy, and at that time her proteinuria is 4 grams. She has normal creatinine and she completed modified Ponticelli regimen. Probably she might have achieved remission then. Later she lost follow-up and she got married. Now she wants to conceive. She is on losartan 50 mg OD and having normal blood
Hello.
pressure. Hello. Hello. Hello.
No, ma'am. You continue, ma'am. You continue.
Tablet.
And there is another case
Saivani,
of
ma'am, can
32
you
years
mute
female,
yourself?
32-year female with fourth gravida.
Deciduous data.
Previous-
అది మనకు మెయిన్ బ్రాంచ్ లో
with
ఉంటుంది చూడు.
previous 2 deaths
Oxymia.
and one live
Ashana.
birth with complicated by antenatal complication like preterm labor, delivered a IUGR baby, and now she was in 8 weeks of gestation, which conceived accidentally as a failure of contraception. Her BMI is 13 and she is a known case of nephrotic now, and she was diagnosed as having nephrotic syndrome, biopsy proven FSGS 8 months ago. Now she is on prednisolone 10 mg OD and tacrolimus 2 mg and 1 mg with 2 antihypertensive drugs with a telmisartan 40 mg BD dose, and the patient is in partial remission. And the third case scenario is 21-year female primey with 32 weeks of gestation and preterm labor with eclampsia with anemia and thrombocytopenia, referred for nephrology department in view of proteinuria of 5.2 grams and serum creatinine 1.8 milligrams. On evaluation, she was found to have low serum complement levels, DNA, dsDNA was positive, and blood pressure is 180/100. Next slide. Before evaluate preconceptional evaluation in every case of pregnancy with nephrotic syndrome, we have to go through the battery of investigations like complete blood picture, liver function tests, renal function tests, complete urine examination, 24-hour urine protein, urine spot protein creatinine ratio, dsDNA and complement levels, and lupus anticoagulant test, anti-cardiolipin antibodies IgG and IgM, and anti-beta-2 glycoprotein antibodies, all these which indicate lupus anticoagulant test, and anti-Ro anti-La antibodies which indicate risk of neonatal lupus and complete heart block in the fetus, and anti-phospholipase A2 receptor antibodies which indicate membranous nephropathy. So preconceptional evaluation, first in the taking the first case scenario of membranous nephropathy, 27 years female, first we have to assess the disease activity, whether the patient is having active disease or she is in remission. After assessing the disease activity, and next we have to assess whether the patient is having risk of progressive renal disease, which is determined by the both clinical and immunological parameters. Clinical parameters which is including serum creatinine of more than 1.5 and progressive declining GFR more than 25% over the last 2 years, and the life-threatening nephrotic syndrome as defined by serum albumin of less than 2 grams and refractory edema and thromboembolic events. Presence of any of these criteria indicates the patient is having very high risk for progressive disease. Next. This is a slide showing the risk stratification of membranous nephropathy.
Joshna madam, slides are not correlating with your talk. Please check, man.
Madam, can you close your window, madam? That one, because I am only sharing you, but in your skin is different and my skin is different, madam.
How to?
Can you close your presentation and just in the Zoom you can see, and I will change your presentation.
Murthy,
Okay.
will you give me the remote? Shall I change the slides?
Okay, I am sending you.
I am not able to change. No, I am not able to change.
I gave it to ma'am.
Now is it visible, ma'am?
Joshna madam, otherwise you take your remote, madam.
No, ma'am. Actually, the thing is, I am sharing the slides, but it
They're
is
moving
not.
now.
No,
Who
this
is
is not
moving
the
now?
slide.
You're in the first slide, ma'am. The opening slide, pregnancy in nephrotic syndrome.
Who is moving?
I am moving. Okay. Madam,
Okay.
preconceptional evaluation. Is it
This
okay,
is
madam?
completed. Yes, ma'am.
Okay. This one.
This
This.
is yes. This is a table showing risk stratification in membranous nephropathy, which is having clinical parameters and immunological parameters classified into low category, moderate risk category, high risk category, and very high risk category. Proteinuria less than 4 grams, 4 to 8 grams, more than 8 grams, and proteinuria of more than 8 grams with the presence of refractory edema, severe hypoalbuminemia, and thromboembolic event. Risk of venous thrombosis suggests low, moderate, and high risk and very high risk respectively. And stable kidney function, previous slide only, ma'am. Yes. If the patient is having stable kidney function and GFR is normal over the last 2 years trend, it is low risk category. And if the creatinine is declining, that is GFR is declining less than 25% over the last 2 years, it is moderate risk category. And if the serum creatinine is declining more than 25% over the last 2 years without any underlying other explainable cause, it is high risk category. If the serum creatinine is more than 1.5, then it is very high risk category. Taking the antiphospholipid plateau receptor antibodies into consideration, if the levels are undetectable or less than 50 radiological units by ml detected by ELISA, the patient is in low risk category and there is very less risk of relapses during pregnancy. If it is moderate risk, if the plateau levels are less than 150, and there is a high risk category if the levels are more than 150. Next slide, please. Coming back to the first case, she is a case of membranous nephropathy who already received modified Ponsonby regimen. On evaluation presently, her creatinine is 0.9, that is normal renal function. Her 24-hour urine protein is 850 milligrams. Previously, she used to have 4 grams of proteinuria. Now she is 850 milligrams of proteinuria and there is no active urine sediment. Her blood pressure is 150 by 90 and plateau receptor levels are less than 50 RA per ml. Her serum albumin is 4.2 grams and hemoglobin is 10.2. So after these parameters and evaluation, we are coming to the conclusion of primary membranous nephropathy with membranous nephropathy biopsy found class 3 and moderate risk category 5 years ago received modified Ponsonby regimen. Probably she might have achieved remission then. Now she is having mild proteinuria, which is coming into the low risk category, a normal renal function, and she is hypertensive. Her low undetectable levels of plateau reflects she is very less risk of progression of or relapses during pregnancy. Now the issues in her case is she needs reduction in blood pressure. Previously she used to have normal blood pressure. 5 years back records show with single dose 50 mg dose of losartan her blood pressure is normal. Now her blood pressure is 150 milligrams, 150 by 90. She needs reduction in blood pressure and reduction of proteinuria also. Hence, we advise conservative management for at least 6 months. And once she achieved complete remission, we have to wait patient disease activity, disease presence should be there 6 months. After that, she can conceive. That's what advice has been advised. So coming to the AC inhibitors and ARBs, AC inhibitors and ARBs are contraindicated in pregnancy. If they are given in the first trimester, they cause embryopathy because of congenital malformations and cardiovascular malformations. Because of renal tubular diseases caused by these AC and ARBs, which causes impaired fetal and neonatal renal function, which in turn leads to oligohydramnios. This oligohydramnios increases the risk of umbilical cord compression and pulmonary hypoplasia and limb contractures. Breastfeeding, many of the studies have shown AC inhibitors levels are very low in breast milk and they are undetectable. Most of the studies are on enalapril, whereas no data of safety on ARBs during the breastfeeding. Caution, the pregnant females who received AC inhibitors and ARBs, they have to be monitored for the 70 to 96 hours after the delivery for the risk of hypotension, oliguria, or transient renal failure in the neonate and the risk of seizures. The pathophysiology being Fetal circulation is characterized by low perfusion pressures and high angiotensin II levels are required to maintain GFR. This angiotensin II helps in the vascular production of vasodilatory prostaglandins, which plays a major role in maintenance of the uteroplacental blood flow and maintenance of glomerular perfusion. So that's why ARBs, which leads to oliguria and transient renal failure in neonates. And sometimes there are case reports of anuria after birth also documented. So in conclusion, the management guidelines being, when a reproductive age group female who is on ARBs or AC inhibitor, first we have to think whether the ARB has been advised for the control of blood pressure. If the patient is having hypertensive and no evidence of proteinuria, we can switch over the class of antihypertensive drugs. If the ARB has been advised to control proteinuria or microalbuminuria, then we have to advise her to discontinue the drug as early as she wants to conceive, or immediately after failure of the contraception, or the best advice we can give her is she has to discontinue the drug immediately if there is any delayed periods for 2 days, and they have to confirm the pregnancy at the earliest possible and to discontinue the medication. Next slide. Beta blockers, which are safe. Beta 1 selective agents are preferred, example metoprolol, whereas atenolol, which is a non-specific beta blocker which causes fetal growth restrictions and shouldn't be used. Child should be monitored for 72 to 96 hours after delivery for those mothers who have taken beta blockers for the risk of hypotension and neonatal hypoxia and hypoglycemia, also sometimes documented in neonates in mothers who has taken beta blockers. Breastfeeding is safe. Drugs which are having high protein binding are excreted low in the breast milk. These pharmacokinetic properties of these beta 1 selective antagonists, because of this preferential pharmacokinetic profile, their safety has been described in nursing mothers. Carvedilol is safer than the bisoprolol because carvedilol is having 95% protein bound and 1% renal excretion. Hence, this is safest in nursing mothers, whereas bisoprolol is having 30% protein bound and 50% renal excretion. Metoprolol is having 10% protein bound and 40% renal excretion, and atenolol is having 10% protein bound and 85% of renal excretion. Though atenolol and metoprolol both are having 10% protein bound, the levels of atenolol in the breast milk and the neonatal blood for mothers who has taken these drugs respectively, the detectable levels are higher in with atenolol when compared to the metoprolol. Hence, metoprolol is preferred and atenolol will be deferred. Next slide, please. Aldosterone antagonists, because of their anti-androgenic properties, they cause feminization of the male fetus. Hence, these are not advised during pregnancy. Spironolactone can be advised in breastfeeding, but it doesn't affect the lactation. And the levels which are excreted in the breast milk and the dose which is delivered to the fetus is also very low. Hence, spironolactone can be advised during nursing. Data on epinol is not adequate to suggest it in the nursing. Digoxin has been used in marine pregnant ladies who are participating nephrotic syndrome with peripartum cardiomyopathy. This digoxin is safe, and this transplacental passage of digoxin has been documented, and this pharmacokinetic property made it preferential for the use of treatment of uterofetal tachyarrhythmias. Next slide, please. Hydralazine and nitrate, those are also vasodilatory group of antihypertensive drugs. They are safe in both mother and fetus. They can be given safely in pregnancy. Use of hydralazine is acceptable in nursing mother, but there is no data for the use of nitrates in the lactating mothers. Intravenous vasodilators like nitroglycerin, which used for reduction of the afterload and the treatment of accelerated hypertension and the reduction of pulmonary edema, it can be used safely in pregnancy. But you have to monitor closely for the risk of sudden drop in maternal blood pressure and deterioration of fetal heart rate. Hence, breast and NTZ has been When patient is receiving NPG, breastfeeding should be avoided. Prescribing diuretics in pregnancy, it has to be balanced against treatment of the edema and volume overload, which makes the patient routine life comfortable. And at the same time, we have to avoid the risk of intravascular volume depletion, which leading to placental insufficiency. Hence, the dose of diuretics has to be titrated. We have to start with low dose of diuretics, and it has to be, prescription should be individualized. Next slide, please. Loop diuretics, as in the complications of loop diuretics, same as in non-pregnant females like hypokalemia, hyponatremia, volume contraction, and metabolic alkalosis. Thiazide diuretics can be used, but there is risk of hyponatremia and bleeding disorders in neonates. So there is no information of diuretics in nursing, but there is a risk of decreased lactation with the diuretics because of the volume contraction. Moderate dose of diuretics, that is 50 mg, is acceptable in nursing mothers when compared to the loop diuretics. Next slide, please. Coming to the second case, which is a 32 years female with bad obstetric history with 2 IUDs and 1 live pregnancy, which is complicated by antenatal preterm labor. Her biopsy is shown FSGS NOS with 20% IFTA and 60/33 glomerular sclerosis, presented with 8 weeks of gestation. Her creatinine is 1.8 milligrams per deciliter and 24-hour urine protein is 1.6 gram at this evaluation after conception. Priorly 8 months back, she used to have proteinuria of 6.5 grams. Now her albumin is 3.5 grams. Her blood pressure is under control with 2 antihypertensive drugs and telmisartan BD. Hemoglobin is 11 grams and she is on prednisone 10 mg and tacrolimus 2 mg in the morning, 1 mg in the night with the trough levels 8 nanograms per ml. Issues are in view of elderly age, 32 years, with the previous bad obstetric history, and now she is having creatinine of more than 1.5, that is her value is 1.8, and subnephrotic range proteinuria, which predict the risk of progression of the disease. A gynecologist and nephrological aspect advise termination of the pregnancy. And moreover, she is on ARBs also. Hence, advise termination of the pregnancy. So after confirmation of the pregnancy, management guidelines are advised by KDIGO. Dietary sodium restriction, that is dietary salt intake should be less than 5 grams per day, and protein restriction, it should be 1 to 1.2 grams per kg body weight. Blood pressure control, the target blood pressure is 130/90, and the minimization of the proteinuria either with immunosuppressive drugs and antihypertensives. Glycemic control, HbA1c target should be maintained at 6.5, but HbA1c in general not taken into consideration in pregnancy because of this independent glycemia independent change in values of HbA1c. And treatment of dyslipidemia. In general, dyslipidemias are treated with statins, but statins are contraindicated in pregnancy. And anticoagulation will be advised in cases with high risk of preeclampsia and those who are having severe nephrotic syndrome, especially membranous nephropathy, which tend to have very low albumin levels and high risk of venous thrombosis. Cessation of smoking and alcohol should be advised, and adequate nutritional supplementation should be given. Next slide, please. Coming to the anticoagulation. Anticoagulation in pregnancy with nephrotic syndrome is advised, especially in membranous nephropathy with severe nephrotic syndrome, serum albumin levels less than 2, and those who are not at high risk of bleeding. Among the all anticoagulants, warfarin and direct to orally acting anticoagulants like argatroban, zimelgatran, or apixaban shouldn't be advised in pregnancy. They should be avoided. Among the heparins, low molecular weight heparins and unfractionated heparins. Unfractionated heparins have the advantage of lower cost and rapidly reversible when compared to the low molecular weight heparins, and they can be safely prescribed in renal insufficiency. Whereas low molecular weight heparins, they are easy to administer and they will have more predictable anticoagulant response when compared to the unfractionated heparins, and there is no risk of heparin-induced thrombocytopenia. and they don't require frequent monitoring as in case of heparins. For persons those who are on unfractionated heparins, APTT should be monitored, and those who are on low molecular weight heparin, anti-factor 10A level should be measured. Use of heparins during pregnancy. Prophylactically, enoxaparin should be given 40 mg subcutaneous once daily if there is prophylactically. So if for the therapeutic, if the patient already had developed DVT and the risk of pulmonary thromboembolism, we have to give enoxaparin 1 mg per kg body weight subcutaneously every 12 hours. Next slide, please. Reversal. There is risk of bleeding in persons who are receiving anticoagulants during pregnancy. So this management of bleeding again depends on the location of the bleeding and the severity of the bleeding and underlying thromboembolic risk. For example, if the patient had DVT in the 6th month of gestation, now she had slight subcutaneous bleeding. In that case, because of the underlying risk of venous thromboembolism progression, this levels of anticoagulant, that is heparin and enoxaparin, the dose can be reduced, but there is no need to stop with close monitoring. Whereas if the person is having previous venous thromboembology episodes 6 months back and they are having bleeding like intracranial bleed or sudden abruption or PROM which leads to imminent labor, in that sort of cases we have to abruptly stop the anticoagulants and we have to think of the reversal measures with protamine. Protamine sulfate is a fish sperm based protein. While administering protamine or prescribing protamine, we have to think of whether does the patient has any allergies to protamine or protamine based insulins also we have to take into consideration. This protamine is safe in both renal failure and hepatic failure. It doesn't require any dose modification. The neutralizing doses will be 1 mg of protamine per every 100 units of heparin or 1 mg of enoxaparin. As the subcutaneous doses of heparin will be released gradually, this protamine has to be administered intermittently. And the dose of protamine which has to be administered again based on the time lapse from the last dose of heparin. Suppose if the heparin has been given less than 30 minutes ago, we have to administer 1 mg. If it is 60 to 120 minutes lapse of time, we have to administer half of the dose, that is 0.5 mg. If it is more than 2 hours, we have to administer 0.375 mg. So when to discontinue this anticoagulants? So American College of Obstetricians Gynecologists recommend we have to stop this anticoagulants at the onset of labor, or if it is an elective section, we have to stop 12 to 24 hours prior to the section. So in pregnancy, we have to monitor fetal activity. In first trimester, we have to confirm the pregnancy, when we have to confirm the cardiac fetal activity, and we have to assess the EDD. In second trimester, DIFA scan has to be done and gross congenital anomalies has to be identified. In third trimester, we have to monitor fetal growth and we have to check for the fetal Doppler velocimetry, which indicates placental insufficiency. And fetal testing with non-stress test and biophysical profile during the final 4 to 6 weeks gestation are done. So review of the medications. Hydroxychloroquine, which inhibit the ligation of endosomal toll-like receptors, can be safely given in pregnancy. It has to be administered continuously if it is a case of SLA, as in the third case. Low dose of aspirin has to be administered for every complicated or nephrotic syndrome, previous nephrotic syndrome with pregnancy. It has to be started as early as 12 weeks of gestation. And there are studies which has shown the early administration of low dose aspirin, that is 75 mg, as early as 12 weeks reduces the risk of preeclampsia by 25%. Coming to the glucocorticoids, which plays a crucial role in the treatment of nephrotic syndrome. There are two types of glucocorticoid, that is short-acting and long-acting, which we commonly use in pregnancy. Short-acting glucocorticoids include prednisolone, prednisone, and methylprednisolone. Long-acting steroids include fluorinated steroid, long-acting steroids, dexamethasone and betamethasone. These short-acting steroids, they pass through placenta and they will be metabolized by placenta, and their levels are undetectable in the fetus. Whereas these long-acting steroids, which are not metabolized by the 11-beta dehydrogenase in the placenta, and their levels are significant in the fetus. Hence, this advantage of dexamethasone and betamethasone gives them safety in administering any neonatal lupus. Suppose the case of SLE, which presents with cutaneous lupus in the previous pregnancy, and now she is conceived and she has subsequent risk of, because neonatal lupus, previous history of cutaneous lupus, there is high risk of congenital heart blocks in the subsequent pregnancies. In such cases, dexamethasone has to be administered if it is in first degree or second degree heart block for transient period, not more than 6 to 10 days. And the administration of dexamethasone is also helpful for the improving pulmonary function in cases of preeclampsia. Also, the lowest possible dose of glucocorticoids which we have to administer is, in general, recommended is less than 10 milligrams per day, unless there are relapses which facilitate administration of high dose of steroids following pulse therapy. The stress doses of steroids during delivery and LSCS, there is a bit consensus varies regarding these stress doses. Whether the requirement of stress doses is needed or not, it depends on the duration of steroids for which the patient has been taking, and the time of administration of the steroids, whether they are administered in the morning or the evening, and the dose of the steroids. Suppose the person is taking 5 mg of steroids in the morning for less than 3 weeks, there is no need of stress doses, because it doesn't affect much on the hypothalamo pituitary axis. The doses of steroids is more than 30 mg for long duration, even though they are taking a morning, they will have the effect on hypothalamo pituitary axis. They suppress the corticotropin releasing hormone and subsequently ACTH. In that sort of cases, we need to administer stress doses at the time of delivery along with the prescribed regular doses. In lactation, glucocorticoids are compatible, and though there are documented reports of cleft palate, there is Denmark study which included 4,800 pregnancies. There is no much difference in cleft lip in the persons who have taken the steroids and compared with the normal population. The risk of the side effects and risk of the steroids are same, are IUGR, gestational diabetes, and hypertension. This next slide, please. Next slide, please. So this is a table showing the stress. If the patient is undergoing minor surgery, there is no need of extra supplement stress dose. The regular prescribed dose has to be taken in morning. Suppose the patient is going through moderate surgical like total hip replacement or LSCS, we have to administer 50 mg of hydrocortisone intravenously just before the procedure, in addition to the regular morning dose. And after the procedure like section, we have to administer 25 mg of hydrocortisone every 8 hourly till 24 hours and resume the normal doses afterwards. For major surgeries like open heart surgeries or esophagogastrectomy, we have to administer 100 mg of intravenous hydrocortisone before the induction of anesthesia and 50 mg of hydrocortisone every 8 hourly for 24 hours. Next slide, please. So azathioprine, safe in pregnancy and lactation. It is helpful in most of the nephrotic syndromes. Methotrexate is a folate antagonist. It is used in most of the rheumatoid disease or rheumatic diseases. Methotrexate has to be stopped, and once the drug has been stopped, we have to allow 3 menstrual cycles to pass before attempting to conceive. Next slide, please. Intravenous immunoglobulins. These are the modulators of inflammatory process through anti-idiotype mechanisms. Intravenous immunoglobulins usage in the relapses of nephrotic SLE, which is compatible with pregnancy and nursing. There is no risk of teratogenicity, though it can cross placenta after 30 to 32 weeks of gestation. Only one case report of transient rash in a breastfeeding infant has been documented. Yeah, cyclosporin, which is safe in pregnancy and lactation also. Tacrolimus, again, it is a safe molecule, whereas cyclophosphamide, because of this life-threatening complications and teratogenic effect on the fetus in the first trimester, it shouldn't be used in pregnancy or lactation. MMF, it is an inhibitor of purine synthesis. MMF will have major effects on the embryogenesis and in the organogenesis. It should be avoided in pregnancy and lactation. We have to discontinue the drug 6 weeks prior to conception. The documented anomalies being facial cleft, microtia, and limb abnormalities like phocomelias. Next slide, please. Rituximab, it is a chimeric monoclonal antibodies against CD20, which causes B cell depletion, which are the precursors of plasma cells. It is safe in pregnancy and lactation. There are some studies which have shown when the patient wants to conceive and the patient has received previous doses of rituximab, we have to give a period of 6 months. Whereas if the patient had severe life-threatening organ damage in the form of relapses, then we can administer rituximab, and there are no documented side effects with the rituximab administration during pregnancy. Next. So case 3, it's a case of 21 years female with eclampsia and diagnosed as having lupus nephritis. It is a supereclampsia, it is a case of preeclampsia superimposing on SLE. So once we are coming across a pregnancy in nephrotic syndrome, we have to monitor. Next slide, please. We have to monitor the disease activity. If the disease in stays prior to the conception, we have to monitor for the disease activity once in each trimester. If the disease is active, it needs very frequent monitoring, like once in 10 days or once in fortnight. Sometimes the physiological changes in pregnancy may overlap with the features of relapse of the nephrotic syndrome per se or the active lupus. So active disease at the conception and those with significant end organ damage has greater risk of postpartum flares. Next slide, please. So the important point, how to differentiate between preeclampsia and SLE flares. Because of the physiological changes of pregnancy, the complement levels will be bit elevated. So while taking into consideration of assessment of activity of the lupus, we have to check for the titers. The sequential titers has to be checked before commenting it whether it is a flare of the SLE because of low complement levels. Because though there are low complement levels because of the disease activity, this physiological change of increase in complement levels may mimic normal complement levels, though there is an underlying active SLE. So active urine sediment and increasing titers of anti-dsDNA will help you in identifying the flare in SLE. Preeclampsia, as we discussed in the previous CME. Next slide, please. So pregnancy in SLE, I think it will be taken up by the next speaker. Fetal losses. Thank you. I would like to thank the organizing committee for giving me this opportunity.
Thank you, Dr. Rajeshwari. That was a detailed discussion of nephrotic in pregnancy, and we have done it case-based and very detailed discussion on drugs especially. One thing I wanted to know, if a patient presents with nephrotic syndrome during pregnancy, so
yes,
doesn't have a pre-existing disease, presenting first time with nephrotic syndrome during
then
pregnancy.
We can do renal biopsy, madam. In general, there is a study from USA, which is completed recently in August 2022, which has included 92 patients, pregnant patients over the 5-year period. We can do biopsy in pregnancy at as early as from the first trimester to the maximum period is 32 weeks of gestation with no complications, ma'am. And even in that 19 cases of nephrotic syndrome, 10 were turned out to be lupus and 4 were IgA nephropathy and remaining were primary glomerular nephritis and 2 cases of PAGN.
Okay, right. Any specific precautions for biopsy? during pregnancy?
Pardon, ma'am.
Any specific precautions we have to take during pregnancy before?
Excellent. Because of there is risk of bleeding in pregnancy, we have to be very cautious monitoring the platelet count. We have to keep the patient in left lateral position by doing biopsy.
Okay, right. Thank you.
Thank you, ma'am.
Thank you, Dr. Josna. It was
Thank
a
you,
very
ma'am.
good presentation.
Thank you,
Congratulations.
ma'am. Thank you, ma'am.
Thank you, Joshna ma'am and Hitashi ma'am. Now moving on to the next session, session 4, pregnancy in autoimmune diseases, SLE and vasculitis. Moderated Dr. Pavni ma'am and presented Dr. Varthi ma'am. Pavni ma'am did her MBBS from SV Medical College, Tirupati, and MD Pediatrics from SV Medical College and DM from Narayana Medical College, Nellore. Currently practicing as consultant at Sri Krishna Super Specialty Hospital since 2013. Over to Pavni ma'am for the introduction of the speaker. Ma'am, you have to unmute yourself.
Sorry. Good morning, everyone. First of all, thank you organizers for giving me this opportunity. The next talk is on pregnancy in autoimmune diseases, especially SLE and vasculitis. The speaker is Dr. Bharati, and she's my junior. And she did MBBS from Karnool Medical College, and she did MD General Medicine from SV Medical College, Tirupati, and she's a gold medalist in MD General Medicine. She did her DM from Nizam's Institute, and she got her first prize in paper presentation in ISHD Con. As we all know, autoimmune disorders like SLE, vasculitis are common in women in childbearing age group. So they have a lot of implications during pregnancy. And directly, without wasting much time, I hand over to Dr. Bharati. Dr. Bharati?
Good morning, everyone. I'm able to hear.
Yes. Yes.
Are my slides visible?
No, ma'am, you have to share the screen.
One second.
Ma'am, you'll find a shared screen icon.
Actually, I
Share the
shared
screen.
on it. Okay, I will exit and I will come. Okay.
Okay, ma'am. Ma'am, your slides are being shared. Yes, ma'am.
Murthy, otherwise share the slides and give me the remote.
Can I do the same thing?
Yes.
Yeah, you share the slides and give me the remote. Yeah, give me the remote.
Bharti ma'am, I think you can start the presentation. The
No,
slides.
Murthy, the slides are not moving.
Okay.
I'm given, ma'am.
No, the slides are not moving then. Slides are not moving, Murthy. Bharati, can you share the slides then?
Yeah, it is coming. You cannot start screen share while other participant is sharing.
Okay. Now you share the
Try, ma'am.
Are you able to see my slides?
Yeah.
Yes.
Okay.
Yes.
Yeah.
Good morning, everyone. Today I am going to speak on pregnancy, issues with lupus nephritis and vasculitis. Before going into topic, First, we have briefly on the physiological changes in the pregnancy. In the pregnancy, there will be increase in blood volume, increase in cardiac output, and there will be increase in level of vasodilators, and there will be relative resistance to vasoconstrictors. This leads to increase in GFR by 50%, and this also leads to increase in urinary protein excretion. And because of these hormonal changes, there will be Th2 polarization in the immunological system, and there will be increased number of circulation of T regulatory cells. And because of this hormonal impact, there will be decrease in systemic vascular resistance, decrease in systemic blood pressure, and decrease in serum creatinine levels. These physiological changes are important because these alter the normal values which we routinely see in our day-to-day practice, that is proteinuria estimation, serum creatinine estimation. So what the normal serum creatinine 0.9 we see in the regular patients is not normal in pregnancy because there will be increase in GFR by 50%. So low serum creatinine, that is the cutoff for serum creatinine normal values in pregnancy is low, that is 0.4 to 0.6 milligram per deciliter. The values more than this, we have to consider the patient is having the underlying renal dysfunction. And because there will be physiological increase in proteinuria because of hyperfiltration, the level of cutoff point for proteinuria more than 300 milligram per day is considered as proteinuria. So already I have told that there will be a Th2 polarization in the pregnancy state because normal pregnancy is characterized by a Th1, which is a cell-mediated immunity to a Th2 polarization, that is phenotype, humoral mediated immunity. This is important for the fetal intolerance. So in autoimmune diseases such as systemic lupus erythematosus, because of this Th2 repolarization, there will be increased risk of preeclampsia, poor fetal and maternal outcomes. So there will the function of T regulatory cells is also not normal in the SLE patients. So pregnant patients with lupus are increased risk of preeclampsia, poor fetal and maternal outcomes. So systemic lupus nephritis. We all know that it is an autoimmune disorder characterized by antibodies to nucleolar and cytoplasmic antigen, and it commonly affects the women of reproductive age groups, and it imposes many challenges in its diagnosis and treatment, especially in the pregnant woman. So up to 75% of the patients with SLE have clinically evident renal disease, and this renal involvement can be either in the form of active lupus nephritis at the time of conception, or new onset of lupus nephritis, or already pre-existing SLE patient can have a flare during the pregnancies. So all these presentation, whether the patient is having active lupus nephritis at the time of conception, or patient is having new onset of lupus nephritis, or if there is any flare during the pregnancy, imposes the risk of preterm delivery, preeclampsia, maternal mortality, fetal demise, and increased rate of IUGR. And SLE features will overlap with the physiological pregnancy changes. So we have to differentiate what are the normal physiological changes and how to differentiate it from the SLE flare. And according to various studies, during the pregnancy in SLE patients, mucocutaneous flares are more common than that of the nephritis flares. And coming to mucocutaneous changes, there will be facial flush, there can be palmar erythema, postpartum hair loss. But in case of SLE flare, the rash is photosensitive and it is typically they are oral and nasal ulcers. Whereas coming to the musculoskeletal system, patient can have arthralgia, myalgia in normal pregnancy, but there will be inflammatory arthritis when it comes to SLE flare. In normal pregnancy, there can be mild anemia and mild thrombocytopenia. But if we come to SLE flare, it can be associated with leukopenia, immune hemolytic anemia also. And coming to the pregnancy-related changes that are seen in renal system, this includes physiological proteinuria. But in case of SLE flare, in addition to proteinuria, which is more than 300 milligram per day, there will be active urinary sediment also. And coming to the immunological changes, there will be higher complement levels in the pregnancy, normal pregnancy, but compared in SLE flare, there will be falling complement levels and raising anti-DNA levels. So these are the differentiating features which we can differentiate from the normal physiological changes from a SLE flare in a patient with SLE with pregnancy. So this is important because we should not give anxiety to the patient simply seeing anemia, thrombocytopenia, mild proteinuria. We have to differentiate whether these are normal physiological changes or is there any active flare in the SLE. And the relation between the lupus nephritis and pregnancy outcome is complex, and pregnancy can have adverse and short-term long effects on kidney function, including the risk of lupus nephritis flare and progression to ESRD. And the risk of progression is determined by the severity of the underlying disease, and it is increased in patients with creatinine values of 1.4 milligram per deciliter. And underlying disease in turn places the pregnancies at high risk of maternal and fetal complications like spontaneous abortions, premature delivery, IUGR, and preeclampsia. So what is the risk of lupus nephritis flare in pregnancy? A recent meta-analysis done by Smith et al. Reported rates ranging from 1.5% to 83% of lupus nephritis flares during the pregnancy. Even the random effect of lupus nephritis flare was estimated at 25.6%. So given the increased risk of maternal and neonatal morbidity associated with active lupus nephritis, the risk of flare as high as 70%, close monitoring with monthly assessment of disease activity is recommended. And this is also one study done by Xing Jian et al. They also done compared the fetal and maternal outcome in patients with active lupus nephritis. This is in comparison between new onset lupus nephritis versus the patients who are already having the lupus nephritis. They showed that pregnant patients with pre-existing lupus nephritis were associated with a high risk of composite adverse events than those with new onset lupus nephritis. However, these two groups of patients had similar adverse maternal outcomes. The long-term renal outcomes were not different after the pregnancy between these two groups. So these are also various studies showing the comparison of the live birth rate, rate of the fetal loss, rate of active systemic lupus erythematosus at conception. All the majority of the studies showed that with disease activity at the time of conception, there is increased risk of the fetal loss and there is decreased rate of live birth rates. And this is also a flow chart showing the comparison of SLE flare rate with live birth rate and rate of fetal loss.
Dr. Sharad Josna, please mute.
So in this chart, we see that if the SLE flare rates are high, there with the fetal loss rate is also high and the live birth rates are low. And this is the chart showing the comparison of lupus nephritis to rate of fetal loss and live births. This also shows that if the rates of lupus nephritis detected at the time of conception are high, there will be increased rates of fetal loss and decreased rates of live births. And these are some of the studies which compared the fetal outcomes and incidence of preeclampsias and incidence of the flares and active disease during the pregnancy. In majority of the studies, the incidence of preeclampsia, the incidence of occurrence of lupus flares, and the incidence of active disease and the decreased incidence of live births was seen. So lupus nephritis causes both maternal and fetal complications. So it is important before patients with lupus nephritis conceives, we have to give proper pre-counseling, preconception counseling to the patient so that there will be good maternal and fetal outcomes. So what are the key clinical questions for treating to target lupus nephritis with pregnancy? Pregnancy planning. The key clinical questions are, is it possible for lupus nephritis patients to have a successful pregnancy? If it is possible, what is the right time to conceive and what should you do before becoming a pregnant? Then next point is preconceptional evaluation. What are the parameters to be assessed before the pregnancy in patients with lupus nephritis? In pregnancy counseling, what is the influence of pregnancy on lupus nephritis? How can you identify the symptoms of SLE flare versus the normal physiological danger during the pregnancy? Once the pregnancy is confirmed, how pregnancy lupus patients with nephritis are monitored? And coming to the patient's care in antepartum care, delivery, postpartum, and lactation. And what are the pregnancy outcomes? What is the influence of SLE with nephritis on pregnancy, maternal outcomes, fetal outcomes, neonatal outcomes? And if the patient is with SLE, it is only SLE, or the patient is having other antibodies like antiphospholipid antibodies or not? And if they have antiphospholipid antibodies, what is its impact on the pregnancy? And what are the medications, which lupus medications can be safely used during the pregnancy? What is the increased influence of SLE related medication? And supplement therapy. What is the most important supplement therapy to be considered for lupus patients during the pregnancy? So all these clinical questions must be targeted before counseling the patients to go for a pregnancy. So preconception counseling. The goal of preconception counseling should be to bond with the patient in pursuit of optimizing her health before becoming the pregnant. And fecundity may be decreased by the presence of antiphospholipid antibodies, progressive renal insufficiency, and previous treatment with cytotoxic alkalizing agents. Before attempting to conceive, teratogenic immunosuppressive should be changed to the most appropriate for the pregnancy. Similarly, antihypertensive with adverse fetal effects such as ACE inhibitors and ARBs should be changed to alternative safe for use in pregnancy. So first we have to risk stratify the patient. So what are the situations where the pregnancy is not advisable in patients with SLE? The absolute contraindication to pregnancy in patients with SLE are patients with severe pulmonary hypertension, systolic pulmonary artery pressure greater than 50 millimeters of mercury. If patient is having severe restrictive lung disease, forced vital capacity less than 1 liter. If the patient is having advanced renal insufficiency with serum creatinine greater than 2.8 milligram per deciliter. If the patient is having advanced heart failure. If the patient had history of previous preeclampsia or HELP despite the therapy. These are the absolute contraindication for SLE patient to become the pregnant. And pregnancy should be deferred if the severe disease flare within the last 6 months, and at the time of conception, if the patient is having active lupus nephritis, and if the patient is having history of stroke within the previous 6 months. So preconceptional counseling and risk stratification. The parameters which are used for risk stratification are SLE activity, lupus nephritis, serological activities, previous pregnancy adverse outcomes, history of any vascular thrombosis, SLE diagnosis, antiphospholipid antibodies profile, anti-Ro and anti-SSA antibodies, and patient whether she is having ESRD or other comorbidities. If the SLE activity is high in the 6 to 12 months prior to the conception, there will be increased SLE flare during the pregnancy, and patient can develop hypertensive disorders, and this will lead to high fetal morbidity and mortality. If the lupus nephritis is active at the time of conception, the risk of renal flare during the pregnancy is increased, and there will be increased fetal loss and preterm delivery. And coming to the serological activity, if the levels of anti-dsDNA are higher and the complement levels are lower at the time of the conception or during the pregnancy period, there will be increased risk of SLE flare during the pregnancy, leading to the pregnancy loss. Majority of the studies showed that compared to the C3 levels, low C4 was associated with more maternal and fetal mortality compared to the low C3 level. And previous adverse pregnancy outcomes, and these are also leads to the increased pregnancy complications. If the patient is having history of vascular thrombosis in the prior pregnancy, this also leads to the pregnancy comorbidities. If the patient is having SLE diagnosis at the time of the conception, this can also lead to the increased pregnancy morbidities. If the patient is having positive antiphospholipid antibodies, there can be increased risk of preeclampsia, IUGR, and preterm birth, and there can be increased risk of the maternal thrombosis. If the patient is having anti-Ro and anti-La antibodies positivity, there will be increased risk of neonatal lupus, leading to congenital heart blocks in the fetus. If the mother had a baby who had neonatal lupus, and with anti-Ro, anti-La antibodies, who had a baby in the previous pregnancy positive for congenital heart block, the risk for second baby to develop the congenital heart blocks is increased for 30%. So if the mother is having a child positive with the congenital heart block in the first pregnancy, it is better to defer pregnancy so that the second child does not develop the congenital heart blocks. And if the patient is having end-stage organ damage or other comorbidities, there will be increased risk of maternal and fetal morbidity and mortality. So these are the risks we have to assess when the patient comes to us before conceiving, or when the patient is diagnosed to be pregnant, or during the antepartum and postpartum also. So first visit, when the patient with SLE comes to us, first we have to assess the risk assessment. So what is the patient's age? Is there any past bad obstetric history? What are the outcomes of the previous pregnancies? And what are the organ affected in the SLE? And we have to look for the baseline kidney function. What is the baseline serum creatinine level? What is her eGFR status? And what is the proteinuria? And we should also assess the SLE activity. If the patient is having active disease, that is last flare is less than 6 months ago, and her serum creatinine is more than 1.4 milligram per deciliter, and the disease activity score is more than 8, defer pregnancy, and we have to discuss the effective birth control options, and we have to treat the active disease in the patient. Suppose when the patient comes to us in the first visit, if the risk factors are minimal and the disease is not active and the last flare is more than 6 months ago, we have to check the medication. We have to review the immunosuppression medications, what she is on at present, and we have to review the blood pressure therapy. If the patient is on teratogenic drugs like MMF or cyclophosphamide therapy, if the patient is on ACE inhibitors or ARBs for blood pressure therapy, we have to change the medication. We have to replace the contraindicated therapy for the safe ones, and we have to wait for the 2 to 3 months with the new therapeutic combination to ensure that the disease remains in the remission. So after the waiting, if the patient parameters have been normal and there is no disease activity and the risk are very low, we have to check for the laboratory testing. We have to go for laboratory testing for pregnancy test, kidney function, urinary analysis and sediments, presence of other antibodies like anti-Ro, antibodies, antiphospholipid antibodies. We as nephrologists will be more commonly concentrating only on anti-dsDNA antibodies C3, C4 levels. But when we encounter the patient with lupus nephritis, we have to also look for the other antibodies which are also positive in the lupus nephritis patients, because associated antiphospholipid antibodies and anti-Ro antibodies will affect the both maternal and fetal outcomes. So what are the drugs which are safe during, what are the drugs we can continue during the pregnancy and we can continue during the breastfeeding? And these table also tells us what are the drugs we have to modify before patients becoming pregnant, so that we have to avoid these drugs before the patient conceives. So common drugs we use in SLE patients are lupus nephritis patients. Conventional medications like hydroxychloroquine, sulfasalazine, colchicine, azathioprine. These can be safely used before conception, during the pregnancy and during the breastfeeding also. But azathioprine passes through the breast milk, so doses should not be more than 2 mg per kg per day. And steroids like prednisone can be used during the preconception period, during the pregnancy and breastfeeding period, and during the breastfeeding period also. We have to taper to less than 20 milligram per day by adding the pregnancy compatible immunosuppressants. If in breastfeeding mothers, if the dose is more than 20 milligram per day prednisolone, we have to delay the breastfeeding for 4 hours. Coming to the cyclosporine and tacrolimus, these can be used in the period of preconception, during the pregnancy and during the breastfeeding also. But we have to monitor the blood pressure and we should also monitor their levels so that toxicity can be avoided. Coming to the non-steroid anti-inflammatory drugs, these can be used in preconception period, and we can also continue them in first and second trimester. But we have to discontinue in the third trimester because there can be early closure of the PDA. And other drugs we commonly used like infliximab, etanercept, adalimumab, golimumab. These can be continued through conception, and we can also continue through pregnancy and breastfeeding. So rituximab, coming to the rituximab, this should be discontinued at the time of conception. And during the pregnancy and breastfeeding, if the patient is having a live, though the data on rituximab is very less, because there is no data that it is totally safe and it is totally dangerous to the fetus or the mother. But if the patient is having life-threatening organ disease during the pregnancy, there are studies which show that rituximab can be used. In those studies, there is no increase in fetal mortality except for the fetal lymphopenias after the delivery. And biologicals like anakinra, belimumab, abatacept, tocilizumab, segunizumab, these can be discontinued at the conception, and these are also, there is no data of their use in the pregnancy. So what are the drugs that are not compatible with the pregnancy? Methotrexate, leflunomide, mycophenolate mofetil, cyclophosphamide. Cyclophosphamide, mycophenolate, coming to the MMF, it should be stopped 6 weeks prior to the conception to assess the disease stability. And the MMF wash also can be the patients who are on mycophenolate mofetil. We can give cholestyramine wash so that there will be minimal MMF levels during the pregnancy period. And coming to the cyclophosphamide, it should be stopped 3 months prior to the conception. Usually, it is not advisable in the pregnancy in the first trimester. In second and third trimesters, if there is any life or organ-threatening disease, these can be used in cyclophosphamide can be used in pregnancy. It is not indicated in breastfeeding mothers. So these are so we have to review all the drugs which are should be stopped before conception and which can be continued during the during the pregnancy period and which can also be continued during the postpartum period and for breastfeeding, so that there will be no teratogenicity effect and there will be safe maternal and fetal outcome. So what are the laboratory testing of lupus nephritis patients during the pregnancy? So at the time of preconceptional counseling or at the first prenatal visit, suggested laboratory tests are urine analysis, proteinuria determination, complete blood count, serum creatinine, antiphospholipid antibodies, anti-Ro, anti-La antibodies. If these are positive, if anti-Ro, anti-La antibodies are positive, we have to conduct the weekly fetal heart rate assessment from 16 to 24 weeks of gestation and every other week thereafter until 32 weeks. And we should also check the baseline anti-DSA antibody levels, complement studies, liver function test. And every month we have to repeat the urine analysis. We have to check for the proteinuria. We have to check for the serum creatinine. If these tests are abnormal, obtain lupus serology and complement studies. Consider a renal biopsy before 32 weeks of gestation. And in every trimester, we have to check for the CBC, anti-DSA antibody titers, complement studies, and liver function tests, especially for patients who are on azathioprine medications. Suppose if the patient is initially negative for antiphospholipid antibodies, but patient should be retested in patients who develop venous thrombosis during the pregnancy. Suppose in the first visit, if the antiphospholipid antibodies are negative, but during the course of pregnancy, if patients develop any DVT, then we have to reassess for the antiphospholipid antibody levels. So the other important, during the course of pregnancy, there can be overlap of preeclampsia, HELLP syndrome, and active lupus nephritis. So what are the clinical features which we can differentiate with active lupus nephritis from preeclampsia? Because the line of management with preeclampsia and active lupus nephritis is different. When coming to the preeclampsia, only delivery is the treatment delivery is the treatment. But whereas coming to if it is patient is suffering from active lupus nephritis, the immunosuppression should be hiked. So these are the differentiating features. Coming to the timing of pregnancy, usually preeclampsia is seen after 20 weeks of gestation, and active lupus nephritis can be seen in all gestational ages. C3, C4 levels are usually normal in preeclampsia and HELLP syndrome. In active lupus nephritis, typically they are decreased. In especially C4 levels are very low. Coming to the thrombocytopenia, it is absent in preeclampsia, whereas it is seen in HELLP syndrome and active lupus nephritis. Active urinary sediment is seen only in active lupus nephritis, and it can be benign in membranous lupus nephritis. Other organ involvement is seen most commonly in active lupus nephritis when compared to preeclampsia and HELLP syndrome. Anti-dsDNA antibodies are positive in active lupus nephritis. Anti-C1q antibodies are high in active lupus nephritis, whereas these are normal in preeclampsia and HELLP syndrome. And liver function tests are abnormal in HELLP syndrome, whereas these are normal in preeclampsia and active lupus nephritis. And serum uric acid is increased in preeclampsia patients, whereas it is normal in active lupus nephritis. Usually preeclampsia BP is common finding. In active lupus nephritis, the hypertension can be present or not. And serum creatinine elevation is commonly present in active lupus nephritis, and it is not seen in preeclamptic patients. But in HELLP syndrome, up to 10% of the patients can have elevation in serum creatinine. So based on these features, we have to differentiate whether the patient is having preeclampsia or active lupus nephritis and decide on the management. So this is the algorithm of the approach to the management of patients with lupus nephritis during the pregnancy. In the first trimester, we have to monitor the blood pressure and we have to assess the SLE clinical activity and disease activity. We have to monitor the kidney function, urinary sediment, worsening proteinuria, worsening renal function, and fetal ultrasound to ensure the intrauterine pregnancy and establish the gestational age. Suppose if the patient is having active SLE disease, increase or add the pregnancy compatible disease modifying anti-rheumatic drugs. Start or continue with HCQ if not contraindicated. And we have to start aspirin 81 milligram per day from week 12 till delivery. Patients with obstetric antiphospholipid syndrome should start prophylactic heparin. Prophylactic heparin is given in the dose of 0.5 milligram per kg in 2 divided doses per day. If the patients with thrombotic antiphospholipid syndrome, we should give the full dose of heparin. Full dose of heparin is 1 mg per kg body weight in 2 doses. When coming to the second trimester, we have to monitor the blood pressure and again we have to assess the SLE activity, urinary kidney function. Suppose if the patient, and we have to look for the gestational diabetic genetic screening if applicable, and fetal echo starting at week 16 through week 25 for mothers who are having anti-Ro and anti-La antibodies positive. Ultrasound to evaluate the fetal anatomy and to assess the fetal growth and placental insufficiency. If the features are suggestive of flare more than 20 weeks gestation, we have to differentiate lupus nephritis from preeclampsia. If there is worsening kidney function, consider the renal biopsy. Active lupus nephritis or the patient is having class 3 to 5, start or increase the compatible immunosuppression. In fetus with evidence of first or second degree heart block, start oral dexamethasone 4 mg daily for several weeks and then assess the response. For the fetus who have third degree heart block without cardiac inflammation, avoid dexamethasone. Avoid NSAIDs at 20 weeks and beyond so that the PDA early closure will be avoided. So when the patient is in third trimester, again we have to assess for the blood pressure, SLE activity, monitor the kidney function and laboratory tests, ultrasound regularly to evaluate the fetal growth, adequacy of amniotic fluid and placental insufficiency. So depending on the test, if there is patient is having any flare during the pregnancy, in the third trimester, we have to start or increase the compatible immunosuppression and we have to check for the medication adherence, and multidisciplinary approach in preparation of the labor and delivery should be planned. So after third trimester, during the time of delivery should be planned at a tertiary care center in the presence of obstetrician and pediatrics. Coming to the postpartum period and the lactation, and we have to monitor the blood pressure, SLE activity, monitor the kidney function and laboratory. And we have to switch to the lactation compatible medication if the breastfeeding is desired. For prednisolone greater than 20 mg per day, avoid breastfeeding 4 hours after the dosing. So this is the algorithm for the approachment to the management of the patients during the pregnancy. So in SLE patients with lupus nephritis, during preconception, during the antepartum period, intrapartum period, postpartum period, we have to assess for the activity of the disease. And if the activity of the disease is high, we have to increase or add the pregnancy compatible immunosuppressive medications, and we have to control the disease so that there will be good maternal and fetal outcomes. Because already in my previous slides, I have discussed that increased rates of active lupus or lupus nephritis during conception or during the pregnancy period, there will be increased risk of fetal and maternal mortality. So all these should be regularly followed up, and the treatment should be planned accordingly so that the pregnancy outcome will be good. Suppose the patient is having active disease, she is on higher immunosuppressive drugs, that is, patient is on a resistant lupus nephritis, despite of having good adherence to the treatment, and she is on high doses of immunosuppression therapy, there is no response to treatment. So is it the end point? That is, can she never become pregnant? Or what are the other options available so that we can help her in getting the motherhood? So every woman who is SLE positive should be counseled for fertility preservation. Women who wish to plan a pregnancy should be counseled about the fertility issues, especially the adverse outcomes associated with the increasing age and the use of alkylating agents. Fertility preservation methods, especially GnRH analogs, should be considered for all the menstruating women with SLE who are going to receive the alkylating agents. And assisted reproductive techniques. Assisted reproductive techniques such as ovulation induction treatment and in vitro fertilization protocols have comparable efficacy in women with SLE and antiphospholipid antibody syndrome as in the general population, and can be safely used in patients with stable or inactive disease. Patients who are positive with antiphospholipid antibodies should receive appropriate anticoagulation and low dose aspirin when they are going for assisted reproductive techniques. And contraceptive measures. Women with SLE should be counseled about the use of effective contraceptive measures like oral contraceptives, subcutaneous implants, intrauterine devices based on their disease activity and thrombotic risk. IUD can be offered to all the patients with SLE and or associated antiphospholipid syndrome who are free of any gynecological contraindication. In a patients with stable or inactive SLE and negative antiphospholipid antibodies, combined hormonal contraceptives can be considered. Women with positive antiphospholipid antibodies with or without antiphospholipid syndrome, hormonal contraception with only progesterone must be carefully weighed against the risk of thrombosis. In patients with SLE, the estrogen preparations are not used for the contraceptives because of the high risk of thrombotic events. Only progesterone preparations can be used. So EULAR recommendations: drug for the prevention and management of SLE placed during the pregnancy. Hydroxychloroquine, oral glucocorticoids, azathioprine, cyclosporins and tacrolimus can all be continued throughout the pregnancy, and these can be used during the flare of the pregnancy. And adjuvant treatment during the pregnancy include hydroxychloroquine should be continued in all the patients unless until contraindicated, because use of hydroxychloroquine decreases the risk of preeclampsia. In women with SLE associated antiphospholipid syndrome and presence of antiphospholipid antibodies, concomitant administration of low dose heparin and prophylactic therapy of heparin should be considered, and supplementation of calcium, vitamin D, folic acid should be offered. So that is about the effect of lupus nephritis in pregnancy. Coming to the effect of pregnancy on the course of systemic vasculitis. So these are the various studies which showed that if the disease is active, there is increased risk of frequent flares, risk of maternal death. And if the disease is inactive, the rates of flares are very low. And the same slide also showing that if the disease is active at the time of conception or during the pregnancy, there will be increased risk of spontaneous abortions and increased risk of stillbirths, preterm births. Compared to other diseases, the risk of spontaneous abortion, stillbirth, and preterm births are low in Behçet's disease. Pregnancy outcomes in patients with systemic vasculitis. Coming to the giant cell arteritis, it is a large vessel vasculitis. So its usually onset is more than 50 years. So the maternal outcomes and fetal outcomes, so that is beyond the reproductive age group. So only few studies are there in patients with giant cell arteritis who had conceived. Coming to the Takayasu arteritis, most patients are diagnosed prior to the conception and flares rate is between 3 to 25%. Most frequent complications are encoded in Takayasu patients are maternal hypertension and preeclampsia. And cesarean deliveries are occurred in 35 to 50% of the population, spontaneous miscarriages in 8 to 30%, therapeutic abortion in 5 to 15%. So all these about these diseases shows that all the studies show that there will be increased risk of preeclampsia, increased spontaneous abortions, and increased risk of preterm delivery and maternal mortality. Coming to the Kawasaki disease, specific recommendations for anticoagulations are not available in Kawasaki disease, and low dose aspirin should be considered in all patients with stenosis or coronary aneurysm, and thrombosis risk should be assessed before conception. And epidural anesthesia with assisted second stage of labor is recommended to limit the hemodynamic complications. And coming to the microscopic polyangiitis, rare cases of diagnosis in pregnancy are seen with worse outcomes and in postpartum rare flares are also seen. There will be increased risk of preeclampsia, therapeutic abortion, spontaneous miscarriages, and low birth weights are encountered in 65% of the reports. Possible placental transfer of anti-MPO antibodies with newborn developing the pulmonary renal syndrome was seen in one study. Coming to the IgA vasculitis, disease onset during the pregnancy was seen in 50 to 70% of the pregnant patients and 10% in postpartum. No disease exacerbations were observed in a study of 27 pregnancy, and pregnancy outcomes are usually good with no maternal deaths in case of IgA vasculitis. However, there is increased risk of spontaneous miscarriages, preterm delivery, and gestational hypertension. IgA are unable to cross the placental barrier, so there is no neonatal complications detected. So in any immune complex mediated disease, the immunosuppression, I think if the disease is active during the conception or at the time of pregnancy, we have to use the pregnancy compatible immunosuppression. We have to increase the dose and we have to get the disease activity under the control. Because if the disease is active, there is increased risk of preeclampsia and poor maternal and fetal outcomes. So planned pregnancy in ANCA-associated vasculitis is safe with low incidence of fetal and maternal complications. Patient should be in remission at the time of conception and on appropriate immunosuppressant therapy. Disease relapse can be treated successfully without causing fetal complications. So there are only few case reports and only few case series on patients who are ANCA vasculitis positive who became pregnant. In those case reports, Rituximab induction therapy for de novo ANCA-associated vasculitis resulted in good maternal and fetal outcomes. And there were successful outcomes of pregnancy in patients with ANCA vasculitis treated during the pregnancy also. So presence of ANCA vasculitis is not a contraindication for a patient who wants to conceive. However, the disease should be quiescent before going into conception. And one specific thing to mention is the patients with Takayasu arteritis, they'll be having abdominal aortic aneurysm. So these patients, when planning for pregnancy, we cannot know what is the stage of aortic aneurysm. While pregnancy is becoming advanced, there can be compression of these aortic aneurysms, leading to hemodynamic instability and maternal death, thrombotic events. So these, in addition to immunological activity, the structural abnormalities also play a role in deciding whether the patient has to continue the pregnancy or it should be medically terminated. Thank you.
Thank you, Dr. Bharati, for the extensive and detailed lecture on pregnancy in SLE and vasculitis. And if any questions are there, we can ask at the end of the CME. Then I'll hand over to Dr. Sindhu.
Thank you, ma'am, for the presentation. Now, moving on to the next presentation, we are running out of time a little bit. So the next presentation, session 5, last session, pregnancy in CKD, by moderator Dr. Sai Vani ma'am, presenter Dr. Niharika ma'am. Coming to Sai Vani ma'am's introduction, we all know Sai Vani ma'am as scientific committee person in Women in Nephrology AP. She finished her medical training from MBBS from SVMC Tirupati, MD from KMC Kurnool, DM from Osmania Medical College, and she's currently working as HOD in Department of Nephrology, Shantiram Medical College, Nandyal. She was a gold medalist in MBBS, Biochemistry and ENT, gold medal in MD General Medicine, and state first in DM Nephrology entrance 2012. Currently, she's 7 years into nephrology experience. Since 4 years, she's working as HOD, Department of Nephrology, Shantiram Medical College. Over to Sai Vani ma'am for the introduction of the presenter.
Thank you, Sindhu, for your nice introduction of me. And going to Niharika, she did her MBBS from Pinnamanini Siddhartha Institute of Medical Sciences, Gannavaram, and MD from GGH Guntur, and DM from NIMS. And now she is currently working as assistant professor in Guntur Medical College. And her topic of interest is clinical nephrology, glomerular diseases, and dialysis. And she got best awards in gold medals in general medicine and pediatrics. Over to you, Niharika, for your presentation on pregnancy and CKD.
Thank you, ma'am. Am I audible, ma'am?
Yeah.
Good morning, everyone. Today I'm going to discuss about pregnancy and CKD. Why we are discussing this topic today? Because pregnancy in a CKD mother is not as same as pregnancy in a normal healthy female. And CKD mothers are among the highest risk population to have the adverse pregnancy outcomes. We all know that pregnancy leads to severe systemic effects, endocrine effects, hemodynamics effects in the pregnant mother. And kidney plays a significant role in the maternal accommodation to pregnancy. So hence pregnancy associated risk increases with the stages of CKD. So what happens to reproductive health in CKD? CKD is associated with reduced fertility, and the studies are showing that oligomenorrhea progresses to amenorrhea as GFR declines, and amenorrhea is present in 37 to 59% of women on hemodialysis. So what is the reason for reduced fertility in CKD patients? The first diagram on the left side this is the normal physiological menstrual cycle. We can see the first half of the cycle, that is proliferative phase, associated with the estrogen elevation, which leads to the positive feedback on the H2O axis, leading to LH surge. So this LH surge causes the ovulation. Whereas in CKD patients, this all the LH levels will be high, but there is no LH surge. There will be mostly anovulatory cycles in the CKD. So this is the HPO axis. There is estrogen production from the ovary. This estrogen stimulates the HPO axis. So from hypothalamus, GnRH will be released. So with the effect of GnRH, anterior pituitary releases FSH and LH. So this LH promotes the ovulation. And during the pregnancy, with the prolactin secretion, which helps in the breast development and milk production, this prolactin inhibits the ovulation. So coming to CKD, there will be decreased estrogen production. So this leads to the negative feedback on the HPO axis. So there won't be the LH surge. There will be lack of LH mid-cycle cells, so mostly resulting in the anovulation. Apart from this, there will be decreased renal clearance of prolactin. So this high prolactin levels inhibit the HPO axis and so leading to anovulation. So the chances of pregnancy is low in the CKD patient. So if the patient is pregnant, so what are the outcomes for the pregnant woman in the CKD? So most of the patients will be having the worst maternal and neonatal outcomes, including higher rates of preeclampsia or the flare of the native kidney disease or the postpartum worsening or loss of renal function in the mother. Coming to the baby, there is the high risk of preterm delivery and the high risk for short for gestational age infants, and there will be the risk of admission to NICs and perinatal deaths. So we all know that CKD is associated with the risk of adverse pregnancy outcomes. So for the patients who are planning for pregnancy, who are not planning for pregnancy, we have to advise them for the safe and effective contraception. Mostly the progesterone only pills or progesterone only subdermal implants are advised. And the patients are planning for pregnancy, we have to give them a detailed pre-pregnancy counseling regarding the natural course of the pregnancy and the associated worse outcomes during the pregnancy. So if the patient is already on any medication for CKD, either for glomerular diseases or for the nephrotic syndrome, we have to advise them for the appropriate substitution of the non-teratogens. So now let's see a case scenario. This case is one of the patients of Saiwan. The history dated back to March 2016. A 34-year-old female known case of CKD presented with 5 months of amenorrhea, and she was married at 26 years, and she had history of regular menstrual history, and she has a bad obstetric history with G6, Gravida 6, Para 1, L1, and history of 4 abortions. So this is her obstetric history. The first pregnancy is in 2008. But it was a spontaneous abortion at the 3 months of gestation. And the second pregnancy is in the 2010, and she delivered a healthy baby girl. And the next 3 pregnancies were eventful. That is the third pregnancy, she underwent MTP in the 3rd month. At that time, her creatinine is 2.9. So first we will discuss about this case, the second pregnancy. So events in the second pregnancy, and the history dated back to September 2009, and her antenatal history is with regular antenatal checkups. There is no hypertension prior to delivery, and she planned for normal vaginal delivery, but as the labor didn't progress, she underwent a cesarean section. But her bad luck, she had a postpartum hemorrhage. She received 2 blood transfusions, and she was discharged home after 4 days. At home, that is after almost 2 weeks, she had history of low-grade fever, pervaginal red discharge. She had anasarca, decreased urine output, and she had excessive breathlessness also. She approached a local doctor, and on evaluation, her RFT were high. Serum creatinine 70 milligrams. So she was referred to higher center for proper care and dialysis. So diagnosis at that time was kept as postpartum AKI. The etiology can be postpartum hemorrhage related ATN AKI or puerperal sepsis AKI, because she had history of fever also and red discharge. That can be bleeding also. And the third diagnosis can be hemolytic uremic syndrome. In the last session, we have already discussed in detail about pregnancy related acute kidney injury. So we can have the differential diagnosis of postpartum AKI or 3rd trimester with the history of HELP, HUS or TTP, acute fatty liver of pregnancy, SLE with APLA, following the sepsis. In this patient, her labs were showing severe anemia, hemoglobin of 5.8, and total counts were 30,800, which is neutrophilic predominance. Severe microcytic hypochromic anemia, but she has normal platelet count, no cystocytes on the peripheral smear. And her creatinine is 15.4. Her liver function tests were normal, electrolytes were normal. Her baseline viral screening is non-reactive. She is negative for HIV, HBsAg or HCV. Ultrasound abdomen revealed minimal endometrial collection and the kidneys were normal. So, because of anuria and higher creatinine levels, she underwent regular hemodialysis alternate day, and because of anemia, she received transfusions also. But for almost a period of 3 weeks, from 30th, she joined around approximately of 10th October until 4th November. For approximately over a period of 3 weeks, she remained anuric and she required hemodialysis. So now we can think of postpartum AKI not improved even after 1 month. And in this 1 month, she received 11 transfusions and 17 hemodialysis. So we can think of peri-diffuse cortical necrosis secondary to postpartum hemorrhage, or whether etiology of AKI not treated properly. We are not sure about the cause of the AKI. This can be ATN related to PPH or peripheral sepsis related ATN also. So patient was reevaluated. Review ultrasound scan revealed retained products of conception inside the uterine cavity. So after evacuation of products on 5th November, urine output started. So after evacuation of products, there is a significant fall in the gradual drop in the creatinine, and the urine output improved from approximately 1.5 to 2 liters. So over a period of next 2 weeks, her creatinine was around 5 milligrams. Now we can say that she was in AKI recovery phase. What was the diagnosis? So we can consider peripheral sepsis AKI due to retained products of conception that lead to sepsis, or we can still think of peripatchy cortical necrosis with partial recovery, because biopsy was not done, so we don't know. We can think of it can be sepsis related AKI or patchy cortical necrosis with partial recovery. But anyhow, over a period of 3 months from October, November, December, she is now landed into CKD. On follow-up, after 3 months, in March, her creatinine was still at 3. So over a period of 1 year, her creatinine was almost stable around, static around 2 to 3 milligrams, and her urine output is normal and anemia is recovered. So at this moment, she is again spontaneously in February 2011 with a creatinine of 2.1. But she undergone MTB with mifepristone, and again she had retained products and she went into sepsis. We discussed that during her second pregnancy, her virals were negative. Now she was turned out to be HCV positive. This can be dialysis related or blood transfusion related. So DNC was done, creatinine was 2.6, baseline creatinine was 2.1, now creatinine is 2.6, mild acute on CKD status. So after 1 year, she again conceived in February 2012, diagnosed at 3rd month of gestation, MTP was done, and the procedure is uneventful. So now after 2 years, in 2014, she again conceived spontaneous abortion. It was a spontaneous abortion, but uneventful. For the last 2 pregnancies, she underwent MTP. For the 5th pregnancy, it is a spontaneous abortion. So during these almost 4 years, her creatinine was static around 2 milligrams. So still she is a case of CKD with normal urine output and with mild anemia. Now 6th pregnancy, 2009, after 7 years, she again, it's the 6th pregnancy, and she was referred in the 5th month of gestational age. There are no urinary complaints, no uremic features, urine output is normal, no fluid overload. Symptomatically, she has no issues, except she was having every month slight bleeding. As we already discussed, pregnancy is associated with worse outcomes or poor outcomes. We have a query whether to advise termination or continuation of pregnancy. What are the indications for termination of pregnancy? CKD as such is not an indication, but risk of AKI, in this case acute on CKD post-termination, will be present. What are the indications for delivery or termination in women with CKD? Inability to control blood pressure or worsening of renal function, decreasing GFR or increased creatinine, neurological abnormalities or worsening of thrombocytopenia or increasing liver transaminase levels, or failure of fetal growth, or reversed or absent endoartery flow and cardiotopography. Luckily, none of these features were present in our patient. So pregnancy was continued, but patient was explained in detail about the risk of acute on kidney injury over CKD during pregnancy or immediate postpartum. And patient was advised regular obstetric checkups, and she was evaluated for risk of progression of kidney disease at each visit. So what are the things to be monitored? Irrespective of the kidney disease, whether it is ADPKD or glomerular disease or diabetic kidney disease or lupus nephritis. So we have to monitor mainly blood pressure, serum creatinine and proteinuria. In this patient, blood pressure is normal, approximately around 100/70 during her checkups, and the serum creatinine is almost static. Her baseline creatinine is around 1.9 to 2, so creatinine is static with 1.9. Her pre-pregnancy GFR around 33, corresponding to CKD stage 3, and proteinuria is also minimal. So her regular antenatal checkup plan, she was advised monthly checkups till 24th week. Then we advised her to follow up every week. We assessed the serum creatinine monthly urine examination and cultures, and ultrasound abdomen and pelvis every month for fetal growth, amniotic fluid index, urinary and dorsal flow, and with strong suspicion on superimposed preeclampsia. So during her 6th pregnancy, vitals were completely normal, no evidence of hypertension or proteinuria, no history of uremia, except she had complained about a small amount of journey to Karnal for her checkups. Her prescription include hematinics and folic acid, but she was not given any aspirin prophylaxis because of bleeding complaints. No HCV prophylaxis or vaccine are given as nothing were available. She had only one episode of UTI during her pregnancy, for which she was treated with nitrofurantoin. So labs during her pregnancy, her BP is almost stable, 100/70 or 90. Her creatinine slight fluctuations between 1.9 to 2 or 1.5 to 2 milligram per deciliter. She had anemia during her course of the pregnancy. Urine PCR is normal, except here it is 0.7. She had in March she had one episode of urosepsis. PCR is slightly high here, and the rest of the course it is almost normal. Her scans were normal, no anomalies. AFA was normal, and uterine artery diastolic flow is normal during all such scans. During culture in the March, Klebsiella was grown, and she was treated with nitrofurantoin for 7 days, and the repeat culture was normal. After completion of 36 weeks, she underwent C-section in July 2016, delivered a healthy male child, post-delivery evaluated for written products which were negative, and discharged on post-operative day 5. So post-delivery labs, she has almost stable creatinine function, around 2 milligrams, electrolytes is normal, urine output is good. She has hemoglobin around 11 grams. Even after 1 month, her creatinine is 2.1. HCV viral load and genotype were done. It was genotype 1A, viral load is very high, more than 2 lakhs. In child, HCV PCR not yet done, but risk of transmission is high because the mother's viral load is very high. So now coming to review of literature, how to manage stage 1 to 4. So the management doesn't significantly depend on the specific renal disorder. We have to monitor hypertension, proteinuria, creatinine, and superimposed preeclampsia with regular antenatal checkups. So main thing is the emotional support, because patient might be having the past history of reduced fertility and past bad obstetric history, and she might be worried about the outcomes of this pregnancy also. So the obstetrician and the nephrologist, they have to give emotional support to the patient. And for preeclampsia prevention, as CKD is a risk factor for superimposed preeclampsia, we have to use medication for preeclampsia prevention. We have to add folic acid 4 mg daily, low dose aspirin, and calcium supplementation should be given. BP should be BP target should be less than 140/90, and diastolic BP should be between 80 to 90 millimeters of mercury, and it should be regularly monitored. And acceptable antihypertensive agents include long-acting nifedipine, labetalol, and levodopa. Proteinuria should be well controlled, and safe immunosuppressive options like prednisolone, CNS, and azathioprine can be used. RAS blockers should be avoided because they can be fetotoxic. And nephrotic syndrome management includes loop diuretics and anticoagulation. Loop diuretics should be used with precautions to prevent the hypovolemia in the mother, and anticoagulation because the hypoproteinemia can lead cause the risk of thrombosis will be there. So she should be advised anticoagulation. And the surveillance should be done with biophysical profiles, fetal growth assessments, placental function studies, monthly in the first trimesters, alternate week in the second trimester, weekly in the third trimester. So, and for the CKD patients, for the CKD mothers, pre-pregnancy or pre-conception counseling should be done detailed, and we should explain the maternal risk of accelerated declining GFR with the need of dialysis during the pregnancy or immediately after the delivery, and risk of severe maternal hypertension, the risk of stroke also should be explained, risk of superimposed preeclampsia with its complications, and nephrotic syndrome with its complications should be explained in detail to the mother and her attenders. And the risk of fetus also are there, and they should be explained, which include fetal growth restrictions, intrauterine death, premature births, complications of drug therapy, and the inheritance of a renal disorder. So what are the principles of antenatal care? So management of hypertension with a target of systolic BP 110 to 140 or diastolic BP 80 to 90. Aspirin prophylaxis should be given. And if the patient is already on RAS block of statins, they should be stopped. Creatinine should be measured regularly once a month. Diuretics should be stopped. And the risk of superimposed preeclampsia should be explained. And fetal status should be assessed regularly. So now coming to management of pregnancy in CKD stage 5. We have already discussed that CKD is associated with reduced fertility. So whether dialysis can improve fertility in CKD stage 5 ESRD patients. So reports, cohort studies have there. So they are showing the results that daily hemodialysis increased patient survival, reduced cardiovascular related hospitalization, BP is improved, better quality of life is there. But whether HD can improve the fertility, the effects of dialysis in fertility are less clear. There are studies that intensified hemodialysis used as a tool to maximize fertility in women with ESRD, resulting in conception rates of 15.6%. So if the ESRD patient on dialysis becomes pregnant, for the hemodialysis, there should be augmentation of hemodialysis dose should be there. Intensive hemodialysis with approximately 43 hours of dialysis per week. That is daily dialysis where approximately 6 hours should be done. And this prescription optimizes the maternal physiology and the minimal use of antihypertensive agents. But these patients still may require preterm delivery. And the most common trigger for dialysis initiation in pregnancy is the fetotoxicity of urea, 15 millimoles per liter, that is 90 milligrams per deciliter. And the other indications for dialysis like acid-base disturbances or fluid volume overload are also considered. For peritoneal dialysis, compared to hemodialysis, incidence of pregnancy is lower in patients on peritoneal dialysis. The reasons might be high dialysate osmolality and fallopian tube injury secondary to peritoneal infections. And if the patient becomes pregnant, the number of exchanges during pregnancy should be increased and the fluid volume should be reduced to 1 to 1.5 liters by switching to APD. As the pregnancy progresses towards term, patient should be switched to hemodialysis at least for 72 hours around the labor period. But the risk of SGI is still high in the peritoneal dialysis patients, 60% in the peritoneal dialysis, 30% in the hemodialysis. The reason being adverse effects on the placental development. So what are the changes to be considered in dialysis patients in pregnant ESRD patients? So at least 24 hours. Standard prescription is 3 times a week, 4 hours. That is approximately 12 hours. So at least we should intensify the dialysis to 24 hours or 24 hours per week in 4 or more sessions. Daily hemodialysis is actually better. Aim for pre-dialysis blood urine nitrogen is less than 40. Ultrafiltration should be limited to 1 liter per session so that the maternal volume will be maintained to prevent the risk of hypotension or hypovolemia. And better to use smaller surface area dialyzer to decrease the ultrafiltration rate. And the heparin requirement may increase because of hypercoagulability of pregnancy. And anemia should be corrected with the target hemoglobin of 10 to 11. So the intravenous IV iron or erythropoietin dose should be increased. So bicarbonate also should be adjusted with oral bicarbonate supplements and dialysis bicarbonate to achieve the normal bicarbonate for pregnancy of 18 to 22 millimoles per liter. And for nutrition, dietitian advice should be taken to for the adequate protein intake with 1.5 to 1.8 grams per kg per day, at least 1.5 grams per kg per day in the hemodialysis patient, and it will be slightly higher in the peritoneal dialysis patients, 1.8 grams per kg per day. And calcium, normal serum calcium should be maintained with additional supplements of calcium, vitamin D, and as well as increasing the dialysate calcium. So all these HT regimen changes should mimic the physiological renal changes of the pregnancy. So most importantly, the patient or the mother requires a multidisciplinary care with a multidisciplinary team involving nephrologists, obstetricians, and pediatrics or neonatologists. So pre-conception, we should counsel her about the risk and the options of assisted reproduction should be given, and dialysis should be intensified to increase the chances of fertility. So the patient becomes pregnant, maternal care include regular measurements of urea, creatinine, blood pressure, anemia correction, and nutritional support. And she should be given intensified dialysis with ultrafiltration approximately 1 liter per session, iron and erythropoietin, and dietetic care should be given. Obstetric care includes they should monitor for cervical length and fetal and placental monitoring. Better to apply cervical encephalitis to prevent the spontaneous abortions. Biophysical profiles for fetal assessment and placental Doppler examination should be done. And the delivery should be done in a tertiary center with a neonatal ICU with advanced technologies. So we can discuss the outcomes, maternal renal outcomes in CKD according to serum creatinine. We can loosely label creatinine less than 1.5 as mild renal dysfunction, 1.25 to 2.5 as moderate, more than 2.5 as advanced CKD. In the mothers with creatinine of less than 1.5 milligram per deciliter, there is a risk of permanent loss of GFR in less than 10% of the women. And the risk is greater if the GFR is less than 40 ml and proteinuria is more than 1 gram. And risk is even higher if the BP is not controlled. There is a 40% risk of preeclampsia if the baseline proteinuria is more than 500 milligrams. The creatinine is 1.5 to 2.5. Here comes our patient. There is a significant risk of decline or permanent loss of GFR in 30% of women, and the risk is increased to 50% with uncontrolled hypertension. There is a 10% risk of ESRD soon after pregnancy in the postpartum period. If the creatinine is more than 2.5, progression to ESRD is highly likely during or soon after the pregnancy. Now coming to the neonatal outcomes. In case of mild dysfunction, that is creatinine less than 1.5, the chance of live birth is high in approximately 90% of the women, but the risk of preterm delivery is high in 50% of the women, and the short for gestational age risk is high if the baseline proteinuria is more than 500 milligrams, that is 60%. There is a moderate renal dysfunction, that is creatinine of 1.5 to 2.5. The chance of live birth is there in 85% of the women, but in patients with uncontrolled hypertension, this percentage will become less, and the risk of prematurity is in 60%. The creatinine is more than 2.5, that is advanced CKD. Fetal loss is very high. So to summarize my presentation, CKD in women of childbearing age confers a risk of reduced fertility and adverse pregnancy outcomes. Earlier stage CKD, as a rule, is a safer time to have a pregnancy. But women at all stages of CKD can benefit from careful pre-pregnancy counseling and careful follow-up evaluation during pregnancy and in the postpartum period. Multidisciplinary team involving obstetrician, neonatologist, and nephrologist is important. Now coming to the role of nephrologist. Nephrologists should be involved actively in pregnancy planning to assist the young women with CKD regarding optimal time to conception, reproductive or preconception counseling, contraception, management of comorbidities, appropriate drug prescription, and increasing the number of hours of hemodialysis provision for better pregnancy outcomes. Thank you.
Good, Niharika. That was a wonderful presentation. And if you have any questions, please type in chat box or Mr. Murthy, unmute the person who is asking the question.
That was a wonderful presentation, Dr. Niharika. Only thing I wanted to stress is nitrofurantoin is contraindicated once creatinine, like GFR is less than 50. It was used in pregnancy for UTI.
Yes, madam, that was my case only. Actually, her urine cultures were sensitive to nitrofurantoin. All others were negative. So I have taken precedence of nitrofurantoin than
Okay.
other drugs. All are resistant, madam.
Okay, injectables
During
are.
yes, madam. And she was not asymptomatic, madam. Only culture was positive. Asymptomatic bacteriuria, and that too, nitrofurantoin was sensitive. Other drugs were resistant.
So GFR wise, actually it is contraindicated.
It should not be. Yeah, madam. Because it won't be excreted in the kidneys. And
only presenters and moderators are in.
They
have to improve like more.
No, ma'am. Rest of the people are viewing on YouTube, ma'am. Actually.
Yes, ma'am.
This
Because
this
YouTube
link is only for the presenters and moderators. Actually.
Okay. How do we know that how many are viewing?
That we have to open that YouTube link, which is on the flyer.
Right. So all recorded session, like all these sessions recordings
are present in YouTube, madam. If you can click that.
So that is where we have to check for them, not in this group.
The link is on the flyer, madam. If you can click on that, they can. We can
the previous sessions.
All
previous
are there, madam. All on flyer.
Okay, thank you.
And any questions?
No questions on the chat box as of now, ma'am.
I have a question. Why we should not use aspirin before 12 weeks, but in assisted reproductive techniques we use aspirin?
Chance of miscarriage.
So chances of bleeding, I suppose, madam. So they stress that they start aspirin after 3rd month, but in assisted reproductive techniques like IUI and all, they will start from the day beginning of pregnancy, after early diagnosis of pregnancy.
Obstetrician's point of view is aspirin promotes the better placental invasion and all, ma'am. So that's why they advise aspirin.
Yeah. But why they wait for 12 weeks? Why can't they start early after confirmation of pregnancy?
And do you have any experience, ma'am? Patients on ESRD become pregnant?
ESRD I don't have, but so many CKD patients at early CKD recently also they have delivered through normal vaginal delivery only. And another experience is one nephrotic syndrome diagnosed at 5th month, but biopsy was chronic IgA. And she went into ESRD after delivery because she had superimposed COVID. Another case is nephrotic syndrome diagnosed, but she is obese and short stature, and they were not willing for biopsy at 6th month. So I have started her on steroids, but after steroids, she was having steroid toxicity and all. So I have started her on tacrolimus. Recently, she delivered through cesarean section because of obstetric indication. The lie was not proper, so they have delivered through obstetric indication. Post delivery also she is fine, but I have to measure the 24-hour urine protein and confirm and do biopsy and see what is the cause. Her ANA profile APLA were negative.
During my DM days, one patient on hemodialysis, she has good residual renal function. She became pregnant, but we advised her FTP.
Oh.
Had a patient of neurogenic bladder. First time she has delivered by cesarean section, like near term, but the second time recently creatinine was around 4.5 and she had a preterm delivery. Again, we had to do a cesarean section. She could not have a spontaneous delivery. So creatinine is around 4 after delivery also.
And another recent one case is pregnancy in UTI in pregnancy, madam. One patient was having pyelonephritis. Actually, urologists defer degestenting in pregnancy because they have to use CM for putting degestant and all. But in that case, as she was going into septic shock, even after 48 hours of IV antibiotics with meropenem and all, so we went ahead with the degestenting without using CM. After after degesting, she improved very well, and now she is on follow-up, madam.
Okay, good. What is your experience of doing renal biopsy in pregnant mothers, ma'am?
That is, I have done one biopsy for that 6 month that was chronic IgA. So while doing biopsy, we have to monitor all those parameters, BT, CT, PT, INR, and better to keep in left lateral position. And actually, ideally in second trimester, but now studies are telling up to 32 weeks you can go ahead with biopsy. But I will do real time only with ultrasound probe on.
Actually, we recently only, ma'am, 3 weeks back, I have seen a patient, ma'am, referral from obstetric department. She is actually pre-eclamptic. Pregnancy was terminated because of IUD. Actually, after seeing her antenatal checkup, she has issue of proteinuria in the 6th month of pregnancy. Biopsy was not done. She was not given any medication in the periphery center. So she lacked proteinuria, she landed into uncontrolled hypertension, pre-eclampsia, eclampsia, IUD, and pregnancy was terminated. Her creatinine was 2. And she even had a sort of flaccid quadriparesis treated as DBS with IVIG and all.
Okay. What about ANA profile and all?
ANA profile is negative, ma'am. We planned for biopsy, but bilateral PCS dilatation is there. Significant PCS dilatation is there. So we started her on IV steroids and given switch it to oral steroids, and we asked her to come for follow-up after 2 weeks so that we can plan biopsy.
And another 2 interesting case of Praki, madam, recently. One is actually 23-year-old lady referred to me with the creatinine of 11 after delivery of 1 week. Postpartum 1 week with creatinine of 11, oligonuria. And on evaluation, she was having hydroerythronephrosis both sides, and uterus was having retained products showing some calcification and all, but she is not in sepsis. Only creatinine was 11, but after detailed evaluation, CT, urogram and all, that ureteric entrance will be there in the bladder. No, there the vagina was very much thickened. She was having forced delivery in the first labor for forced normal delivery. That time she was having uterine prolapse, and after 2 years of first delivery, and so she was kept on pessary, and this delivery was planned. After 3 months of pregnancy, that pessary was removed, and now the issues were bilateral hydroerythronephrosis with creatinine of 11, oligonuria. So we have done 2 dialysis, but she was not in sepsis, though those retained products were there. But obstetric point of view, they have tried for DNC, but they couldn't because of cervical stenosis. And they told during first pregnancy, because of forced labor, she was having that uterine prolapse. So this cervical and uterine anatomy was not aligned. Because of that, she may be having hydroerythronephrosis. But our urologist is telling during second cesarean section, they might have tied ureters, so she might have having bilateral hydroerythronephrosis. But the antenatal scan was not there to know maternal kidneys, whether hydroerythronephrosis was present prior or after ligation of ureter, so we don't know. But one side he could pass degestant, and another side we have done PCN. Now her creatinine is 0.6, and that ureteroplasty has to be done after 6 months. Another second interesting case is Praki. She is priming and on regular follow-up. But at 8-month gestation, she had sudden development of pains and bleeding with severe hypertension, and that obstetrician, as they were not giving high-risk consent, she referred the case to Government General Hospital. There some delay was happened, and they took her to other area, and there they have delivered and received 4 blood transfusions, and I think she went into shock, and she referred to me with creatinine of 2 and anuria. She was having acidosis, so we went ahead with the dialysis as she was anuric, and biopsy was showing cortical necrosis. And after 2 weeks, her urine output opened. I thought it may be patchy cortical necrosis. Her urine output was open, but after 2 weeks, and I have discharged her by removing jugular. But 3 days after, she came with creatinine of 10 with fluid overload. Though she is telling urine output is normal, she might require dialysis for some more duration. So these are the interesting cases of brachy I have encountered in recently. Hitashi madam, your experience, ma'am.
No. I have no patients of dialysis getting pregnant.
Okay, ma'am.
I have 2-3 patients of patchy cortical necrosis were on follow-up, and one of the patient conceived again but lost for follow-up.
Okay.
Recently, one patient, second pregnancy, that patient had proteinuria and was seen at CMC, and they have started on steroids and cyclosporine, and then the patient lost for follow-up and discontinued the drugs. And third pregnancy, again, she had proteinuria in early pregnancy, and that time she was not referred to us. So around the 8th month, she was referred with frank nephrotic. So that time, can't take for biopsy and all that.
Yes.
ANA was positive. We have started steroids to just continue till delivery and then plan biopsy later. She was delivered by cesarean, I think, and then it was all uneventful. So she continues to have edema and proteinuria, and then we have advised biopsy. She has to come.
Okay.
There's not yet come.
Okay. Pavani madam. Pavani madam.
For us, one problem is because Tirupati is near to Chennai CMC.
Vellore, yes, madam. So many.
And many of the patients have advised termination because there is a progression of CKD during pregnancy.
Okay.
And patients already with raised creatinine, with increased in
Rather than mother. And lot of counseling should be done.
Yeah.
And majority of these patients will be ANA positive, madam. SLE, even it may be renal limited. ANA may be negative, but after renal biopsy, it looks like lupus only. Majority of the cases. So, Sindhu.
Thank you so much, ma'am. I have just finished my course now. I don't have much experience, but yeah, I have seen a lot of quite a number of nephrotic syndromes during pregnancy when I was doing my DM in Ramchandra. And we, with a very low albumin, less than 2.2, we started them on anticoagulants, low molecular weight heparin even with normal renal function. And then switched to oral post-pregnancy, and we did a biopsy. A couple of them turned out to be membranous nephropathy, and yeah, mostly it's SLE everywhere, but I have seen a membranous nephropathy coming out during pregnancy.
Okay. Recently, post-COVID era, membranous nephropathy is becoming common in biopsy specimens, ma'am. But I don't.
Even in younger patients.
Two consecutive patients with nephrotics, both are from Gulf.
Okay.
Both are in like 20-30 years age.
Okay.
And both had some like ortho problems, some severe knee pains, one patient, the other patient with low backache and radiating to lower limb. They took some NSAIDs and then presented with one patient with nephrotic, other patient has nephrotic proteinuria but no edema. Both are membranous, nil positive, flour negative.
Okay.
Just this is in last 1 month, one and a half.
Yes, ma'am. Recently, we are seeing more membranous, madam. One patient who was having 5.6 grams of proteinuria had spontaneous remission. 2 times I have tested for 24-hour urine protein. I don't know. I didn't reach her on only Telvas 40 mg I have kept, but she underwent spontaneous remission. Another membranous, she is not willing for this ponticelli, though she was having 15 grams of proteinuria, and she was not tolerating TAC also. I have kept her on Telvas only, thinking that she might also go into spontaneous remission.
So I knew that
But these young females, if we closely poke them, these dermatologists are giving a lot of mercury-based skin creams for skin lightening.
Yeah,
I've seen
yeah,
a couple of cases of membranous nephropathy with after using some skin cream they're not aware of, and they turn out to be proteinuric, and if we just go through that, because these days because the cosmetology and aesthetics is on rise, and they're giving a
yeah,
lot
yeah,
of
yeah.
mercury-based creams. And that
Recently, one psoriasis patient, the biopsy was turned out to be membranous. Mostly that may be because of this dermatology treatment. He received Ayurvedic medicine. We have to analyze that Ayurvedic preparation. It might contain mercury.
Psoriasis patients, they use a lot of Ayurvedic.
Yes, ma'am. Yes, ma'am. Alternative.
Most of the times, unless we poke, they don't reveal us.
Yes, ma'am. And with our Ponticelli, that psoriasis came down. He recovered well.
Yeah, that's an additional advantage. We can tell them and then convince them for that.
Yes, ma'am. For biopsy. Okay.
We had a good session.
Thank you, ma'am.
Very crisp and orderly session. Thank you.
Our speakers spoke very well. So thank you, all of you.
Thank you, ma'am.
Thank you.
Niharika, your slides are very good.
Thank you, ma'am.
Ma'am,